Good morning, everyone.
Oh, we're live. Good morning. Good morning, everyone. I was just finishing. Thanks, David. Thank you. I appreciate it. Good morning and welcome to PerfWeb number 71. I'm here in the studio with my good friend Tammy Sparacino, and of course, we'll be doing coming to us from Nashville is going to be Joey Lepore and Matt Warhoover with Vanderbilt and the Vanderbilt Faculty Forum. Do you want me to do the opening remarks, or what do you want me to do?
Yeah.
Okay, great. Sponsor is HET. We're the best perfusion group in the whole world. If you want to join an incredible group, I do believe we're still hiring.
We do.
And
Yeah.
although we're seeing some down trend in our COVID ECMOs, we are definitely still now we're going to go into full expansion mode with our perfusion service and do lots and lots of hearts and lots of places. We're just a really good group. We're fun. We're professional. We do a great job. So that's our sponsor, ourselves. Social media, please make sure you like, follow, share, subscribe, give on the Facebook, the YouTube, and the Twitter, and give us the thumbs up on the YouTube and click the bell icon. Make sure you subscribe if you haven't already done that, and make comments, because the more comments you make, like our good friend from Azerbaijan, I hope I said that right, Azerbaijan, right? I'm not going to try Kunyet. I'm not sure how to pronounce that name, but good morning to you, and we are grateful that you're here with us. Check our websites out, perfusioneducation.com and perfweb.us. I've explained all that before. Contact us at perfusioneducation.com. So you see it down there on the lower third, they call it, I think. And our call-in number, you want to be live on the air, we'd love to hear from you, call in. Check out our MediWeb app, and you can find this on the Apple Store, the iTunes Store, I think, and you can also find us on the Google Play. So check that app out. It's really good. We're getting ready to do a big update on it. Magic wants us to do one little update every month, but I'd rather do one big update. But either way, the updates are free, so check it out, get it now, and we'll continue to update that. Podcast, you can check us out on whatever your favorite streaming service is, and there it is right there. And it's the PerfWeb podcast series, so you can listen to our programs. I think they're informative and entertaining. And there's Matt. I see Matt walking in. So we can see him in Nashville. There he is. Man, I'll tell you what, that is one good-looking guy. There's not a whole lot, there's very few people that are better looking than me, but Matt Warhoover and Joey Lepore, that's a pair right there. I'll tell you what. Anyway, with that said, good morning. Good morning, Tammy. Good morning, Matt. Good morning, Joey. Let's play the intro for the Vanderbilt Faculty Forum, and then they're going to... You did that already?
Did that.
And so there they are. There's Matt and Joey. Matt and Joey, the floor is yours, sirs. Can we hear him?
Well,
there he
yeah,
is.
well, thanks, Joe, for having us.
Dude, are you kidding me? Thank you for doing this and taking the time out of your Wednesday mornings and all the time it takes to put this stuff together. We appreciate you. Our audience appreciates you because we've really enjoyed this. This has been, I hope you guys are seeing some increase in, contacts, I guess, really is the end of the day is trying to connect all of us together. But I hope that this has been as valuable for you all as it has been for us, because it's been tremendously valuable to us.
Well, I'm glad to hear that. We definitely had some more contacts concerning the content. In fact, I've directed about a half dozen to a dozen people to watch today's episode, as this is kind of a real hotbed of a topic, kind of unique to Vanderbilt and a handful of other places across the country, but it's really starting to take off as far as the idea about DCD cardiac transplantation, and with the we'll get into it why it's really obvious that this is the direction it's going to go.
Yeah, I'm very interested in hearing this. I know we had planned on it being something else today. The guys had, I think, the wrong title up or whatever. But I think this is a much more timely and a much more relevant topic, actually. And because we have all of, in fact, we need to get together because we have all of 2022 to really start thinking about. And we're meeting today after the program to discuss what plans we have for the future so we can maybe change some of the stuff that we're doing to make it a little more exciting for people, bring in some new ways of doing things, and I'd like to get your guys' input on that as well. We're going to meet, and then Tammy and I and Min, probably Magic, no, but we're not going to bring Magic again, but we're going to bring Min because he was so upset we didn't bring him the last time to Nashville and talk with you all, because for us, I don't know what you all are seeing, but the pandemic is, at least I hope we don't have another surge, but hope is not a strategy, so I'm planning for another surge, but I'm still very hopeful that we may have seen the worst of this at this point in time. I don't know if that's what you're seeing.
We are seeing a small decrease in the numbers over the weekend, a little bit up, but I think that's just a blip on the radar. It's not like anything it was 3 or 4 months ago.
Yeah, very good. Okay, I'm sorry. I'm going to stop talking now. I'm going to turn my mic off and listen.
No problem. I just want to thank again for having us. Joey's going to have to take off. One of us has to make this meeting this morning at 7, and so he's going to take off. And I just wanted to thank him for being here with us. And if his meeting gets over, he'll be back.
Okay. Sounds good. Joey, it's good seeing you, man. How's life treating you? Is it well? You doing well?
It's good, Joe. How are you?
We're good. How about your family? They all doing well?
Everybody's good. Just celebrated my wife's birthday, so everything is good.
Fantastic. Well, congratulations. Happy birthday to her. Make sure you do something nice.
Thank you. I'll try.
All right. Without further ado, we'll get on with the. So we've had a lot of phone calls lately and a lot of really emails, all kinds of inquiries about this DCD heart transplantation that we're doing, and we call it NRP just for short. It's the normothermic regional perfusion. Essentially, what it is, we can go to next slide. Essentially, what it is that we're going non-brain death donor, and the family has requested that they become an organ donor. The patient had already consented to be an organ donor, and unfortunately, they just don't make the qualification of actual brain death. The family and the medical community decides that they are not going to have a functional life after whatever incident took place, and what ends up happening is that they're told.
Hey Matt,
typically in the operating room.
Hey Matt,
but we have done it in a post anesthesia recovery area, PACU area, and then after the patient officially passes into the operating.
Can we get his attention, please? Because this is important.
Everything okay?
Hey Matt, yeah, your connection is bad. Like you're fading in and out, and this is so important. I don't want to lose
Sorry
it.
about that.
No, that's okay. It may be feedback. Do you have my mic? Do you have what's going on? Do you guys know? Because this is really important stuff, and I want to make sure that our connection is good.
Is that better or not?
Yes, that is better, actually. Just do a countdown for me. 5, 4.
5, 4, 3, 2, 1.
That's good.
That's better. Yeah. Much better. Okay. Yeah, I'm sorry. Could you go ahead and just start with your DBD again? Because I think we really missed some important pieces.
Mm-hmm.
Yeah, so essentially what we're doing is we're being contacted by an OPO that there's a patient out there that doesn't necessarily qualify for brain death. And so, because the patient, is an organ donor by choice, they've elected prior to the incident or the event that happened to that they want to be an organ donor. The family and the medical community and the medical staff that's taking care of them has determined that they probably will not have any more functional life because of the event. However, they're not quite considered a brain death donor. So what ends up happening is that with the consent of the family, the medical team will withdraw care on the patient, and they will die naturally, a cardiac death, and that's where you get the donation after cardiac death. The withdrawal usually happens in an operating room in a fixed environment. We have had it where the patient, is withdrawn in the post anesthesia recovery area or a PACU, and then they're quickly wheeled into the operating room after their death. But we prefer it to be in an operating room. It's a lot more controlled. It's it's very organized, and that's how we prefer to do it. Sometimes region to region, state to state, even institution to institution, they have different policies set up on DCD. It can be a 2-minute standoff period, a 5-minute standoff period. You can drape the patient sometimes you can't. So it's very unregulated currently of what you can and can't do to patients prior to them expiring. Essentially, next slide. Essentially the first cardiac donations were the DCD because the technology wasn't available to actually determine if people were brain dead officially. So there was landmark cases after the fact, and actually Colorado had the first pediatric experience of how cardiac donation was more or less set up years and years ago. Next slide. And this is a paper that is really it delves about the DCD, the outcomes of heart transplantation. It's an international experience out of Australia primarily, and this is where it really caught kind of wildfire in the more or less in the international community. The Australians and the New Zealand teams were some of the first ones to delve into this, and it really paved the way for the European experience and the North American and the Asian experience, and everybody is doing this now. Next slide. And then finally, you're looking at what are these outcomes looking like versus your regular brain death donations, and really we're not seeing much difference at all. Not we, the community is not seeing much of a difference at all in the outcomes on your 5-year experience. Next slide. So this is where I find it's the most compelling argument, and kind of a forum like this, this is a talk, but as Joe, as we always do, it's really a formal roundtable. So this is the slide that I really want to kind of fix on and actually have some interaction with. We do 2,600 DC donors across the U.S. We can just scroll through some of the data there. And half of those are donors under the age of 35. So they're fantastic organs as far as from a chronological age and from the length of time that someone that's going to receive this valuable gift, how long that donation is going to last for them. And so if you just look at if we were going to use just 30% of those organs, we would have an increase of 400 hearts a year. And the reality is that is a huge number in comparison of what we do cardiac-wise across the country. Next slide. The advantages of the brain death is that we have a high quality. I'm sorry. The advantages of a DCD donation is that whether we like it or not, our younger people tend to have I don't want to say a higher incident of accidents and or neurological devastating events that happen to them. That's just the nature of unfortunately young people. They recover. They can actually make it through an event, whether it be an automobile accident, a drug overdose. And those patients are viable organ donated. Viable people that can actually donate to transplantation, and a lot of those times those organs are just being discarded. They're perfect organs, and there's people out that are really needing those. Unfortunately, unless they are prior to the incident a donor, they're not eligible. So it's only people that actually have signed the card, have done a medical waiver that is attested by some sort of witness. That's the only way that these people can be donations. So if they're not donors prior to the incident, the family cannot consent to do that. Next slide. So the disadvantages of DCD is that there is definitely a warm ischemia time, and we're going to play a video at the end of the talk and show exactly from knife to skin to getting on a bypass machine, what that involves. But there is definitely a warm ischemia time. So when the patient is beginning to expire, you get a loss of blood pressure, you get low sats, and organ deterioration is happening. You're getting poor end organ perfusion. And so at a MAP of 50 is when the international community has decided that is when we start more or less a warm ischemic time. As warm ischemic time goes longer, there is a risk of post-graft dysfunction after transplant. And we still don't know the long-term risks. We know there are long-term risks. We just don't know where that cutoff line is with this warm ischemia time. And to be quite honest, it's more technically challenging the longer the organ goes under a warm ischemic period. It's more technically challenging. The heart actually dilates more, and you may or may not be in the video, but we definitely see it when we're doing these. Next slide. And then the conventional DCD recovery, like I said, there's a high risk for warm ischemia and non-recovery. There's an increase in organ injury, and the reason that is it is a controlled environment, but they call it time as tissue. And so from a knife skin incision to a sternotomy to opening up the pericardium to making sure that you get access to the head vessels to clamp them off, and we'll talk about that as well. There's a lot of things that are going on rapidly. You want to do it in a controlled fashion, but everybody is moving pretty quickly. And many times, whether it be a cannulation injury where you get an aortic dissection, or you get a hematoma on the aorta, or just cutting in, sometimes you can get into the right ventricle. There's risk of injury to the actual organ when it comes to the cardiac through the sternotomy. Cannulation happens all the time. These cardiac surgeons are cannulating all the time. The problem is that they don't cannulate on a flaccid aorta very often. And you can imagine, the heart. There's no heartbeat. It's the heart is asystolic. The aorta is flaccid, and so trying to cannulate a flaccid aorta can lead to some innate problems just in itself.
That makes sense.
And then you want to combine that. You want to take. There's always I say always. Many times there's kidneys and liver teams that are there but we're starting to see more and more of lung DCD donation. And so when you combine that you have 4 teams on a chest, or on the patient that just recently expired. You've got 4 teams, usually 2 people per team scrubbed in. I want to say it's organized chaos, but it is very there's a very important, and there's an impetus on time. Everybody, they're announcing every 30 seconds how long our warm ischemic time has been from its skin incision. So the whole idea is everybody in the room is under the gun, if you will, to try to get the organs turned back around. And the protocol for prepping, extubating, standoff time, that's all variable from institution to institution, state to state. And then when you add putting the lungs back into it, the patient is usually extubated most of the time. Sometimes they'll just disconnect from the ventilator with the ET tube still in place, but most of the time they're fully extubated, and then the patient has to be re-intubated. So there are some other things going on outside of the sterile field. Next slide. So really what it is, it's a little bit of organized chaos. It is a sternotomy, then the rapid cannulation perfusion of the patient with a warm blood for about 45 to 60 minutes, and then we reanimate that. And then what happens is after 60 minutes of warm perfusion, we go into the cold storage where we do just like a regular brain death. We'll cross-clamp, we'll give cold cardioplegia, and then the donation plays out just like every other brain death donation. Whereas if you go where the OCS is, the reanimation is on the OCS. So the difference between the DCD NRP and OCS is OCS, they just do a regular cardioplegia delivery, cut the heart out, put it back on a machine and reanimate it. This is actually being reanimated in the donor for a fixed period of time until we can get all organs turned back around as far as with good oxygenated blood, get all the metabolites washed out, and then we proceed with a regular cold storage donation. Next slide. So this is what the NRP actually looks like in the chest. We have a mobile. Actually, it's a mobile ECMO circuit that has a cardiotomy reservoir in it. We used an ECLS circuit. The very first thing we do before cannulation, the head vessels are exposed, and there is a large cross clamp that's put across all the head vessels. So no perfusion ever actually goes to the head or to the upper limbs from the 3 head vessels off of the aorta. And then what you do is you continue to perfuse the lower body, and then there's an assessment of the organ function for all those that are taken, whether it be kidney, liver, lungs, and heart. We're actually able at times to also take pancreas and small bowel as well. Those teams are in the room, but they're just not in the field at the beginning. And the reason why it's important to have all teams available, if the cannulation does not go well to place the patient on our pump, the cardiac team backs away immediately, and all other organ procurement people proceed as a regular DCD, not an NRP DCD. So we've dissected the aorta before, not able to get good perfusion to the donor, and so the cardiac team has to immediately back away because we're actually just causing more warm ischemic time for those other organs. Next slide. And this is this is kind of a tough slide for everybody to see, but this is a timeline of events that I've kind of discussed. can't really see it really well as far as the screen, but what essentially happens is there's a timeout. We all discuss who we are, what teams, what's going to happen. That's prior to doing it. All the teams walk out of the room that are affiliated with the procurement. The patient with the medical team on site that's taking care of them. The patient, they withdraw care, and one of the nurses actually sends vitals out to the procurement teams in a separate room. And so we continue to watch the vitals. At some point, the patient will go agonal, anywhere between instant as soon as they withdraw care and extubate. Sometimes they'll immediately go agonal. Sometimes it takes two hours. Now the family is in there with them. Usually, they've got an arm out, and the family is there in the operating room. And so they get to experience, taking care of their loved one, whether just like if they were in an ICU. And so there's a attending physician in the room. Once the patient expires, the family is escorted out of the room. The family leaves. The procurement team usually comes into a different doorway, and then there's the 2 to 5 minute standoff. The attending physician that's taking care of the patient identifies what time the first time of death was, and then the standoff period happens. He or she listens for a heart rate over a sterile sheet, and after the 2 to 5 minute standoff, we'll listen again. If they're declared deceased, the sterile sheet that they were listening through gets taken off, and the teams immediately start to make incision. What happens is there's a regular skin incision from in the chest all the way down through the abdomen. There's a sternotomy that takes place, and then there's a opening of the pericardium. There's exposures of the head vessels. Big clamp goes on the head vessels. A right atrial incision is made. We cannulate. We drain. The reason we drain is the heart is distended this time. It's very big, and to reduce the amount of wall stress and energy ATP consumption, we drain the patient out, and then an aortic cannula is placed in the ascending aorta, and then we go on usually with 2 to 3 liters a minute. There's no purse strings put in at this time, and so it's very important that the assistant is holding both the atrial and the aortic cannula in place. The cardiac surgeon sews purse strings around the cannulas. Once they're in, then we usually come up to about 5 liters, 6 liters a minute, and we try to promote an index of about 2.6 to 3 on the patient to hyperperfuse them. Once we're on like that, the cardiac team will put in a PA vent, and that's to vent the right heart, mainly just in case the heart doesn't come back in a good rhythm. We're protecting that right heart. About 90% of the time, by the time they get the atrial stitches in and the aortic cannula stitches in, the heart has already come back to a normal sinus rhythm. If they haven't at that time, we'll shock before we put the PA vent in. We drain. Once all cannulas are in, the cardiac team steps away, lets the abdominal teams really get good visualization of their organs and get the blunt dissection down to the vessels that they need to as well. We perfuse for 45 to 60 minutes. A cross clamp is put back on the aorta. Pump is stopped. We drain through the right atrium, and a cardiopulmonary solution is given, just like a cold storage. All the other organ systems are being perfused at this time as well, and we drain all the perfusate solutions from all the organ systems back into our cardiotomy reservoir. And regular organ donation continues after that, and everybody goes their separate ways. Next slide. And so this is our pump on the right. you can see we use a Levanova trolley system, and then we just have a cardiotomy, a Medtronic cardiac reservoir centripetal pump. We use a vacuum assist, and we hook 2 pump suckers up to that are only used by suction. We don't have roller pumps on this. It's very mobile. And then this is our back table. This is the back table setup that we have. The lines are already put up on the chest, and as you can see, we've got really everything we need right there. And the assistant and the cardiac surgeon that's procuring, it's a very orchestrated event. Everybody talks about what the plan is on the plane. We get there on site just in case there's a change. We talk about it again as a group, and everybody knows their roles, and it's a pretty efficient process. Next slide. So once we're on pump, and the vent is in, the cardiac surgeon, once the other team kind of gets started on their organs, they'll place a cardioplegia needle that we hook up to a pressure transducer back on our trolley system, and we'll watch the hemodynamics, mainly because once the head vessels are clamped, our right or left radial artery, we can see an EKG come back because they've got the ECG pads placed on the donor, but usually, when we have that cross clamp on the head vessels, we immediately lose the art line. So we're actually perfusing blindly as far as a pressure. Now the surgeon can have a tactile feel on the aorta, and they can give us their best estimate. But what we usually do is we'll put a cardioplegia needle in with a transducer back, and we know that we're going to use that same needle when we procure the heart at the end of the reperfusate time. We're taking labs back there for the manifold, just like we would do it on a heart-lung machine. We run lactates, and we run pH, ISTAT, CG8 and CG4 cartridges. We'll give bicarb, we'll give calcium, we can give insulin, we can give dextrose. We have the full complement of potassium, we have the full complement of electrolytes and drugs to try to best turn the organ around. And so that's really all we can do from an NRP. When you do OCS, you actually can see what coronary flow is. You see instant pressures, and you're trending lactates that are specific to the heart, not global lactates like we do in NRP. Next slide. And then really the other difference between NRP and which is versus the OCS is the distance. We recently did a 2-hour and 45-minute flight last week, and that's the longest we've gone with NRP. It had a total ischemic time of 4 hours and 45 minutes. Patient, the recipient did fine, the organ was fine, but that's pushing the limits. Anything over 4 hours of ischemic time, we know that the organ starts deteriorating rapidly. So really, that's about 2 hours and 45 minutes of airtime is what we were. That's not ground transportation to and from the donor and to and from the recipient. So that we've really pushed the limits. That's probably as far as that we're willing to go. Whereas with the OCS, you have 14. The people out of Australia and New Zealand, they've had it on the box for 14 to 16 hours. The most we've done here at Vanderbilt is 10 hours. 4 of that is really was sitting in-house already, just trying to see if the organ was going to turn around, and it did. It just took a longer time. But we really, about 5 or 6 hours, 7 hours is really our typical organ run. Next slide. Predicting demise. It's reflexes. Are you breathing over the vent, and are you needing hemodynamic support as far as with phenylephrine, levofed, that type of thing. Age, and I will throw one more thing in there. The predictability of what the insult was. Was it an acute event? whether it be or was this a conditioned event over time, is also kind of a predicting whether the patient will expire within the time frame of, of, of your warm ischemic window. With OCS, the warm ischemia window starts with a SAT of 70, less than 70, or a mean arterial pressure. What we've done with the NRP is that we've just decided that it's just going to be a mean of 50. We don't feel that the predictive measure of a SAT on the finger really predicts what is happening at the cardiac level. Your heart is seeing the most oxygenated blood in the body, and so we don't feel that a pulse ox on the finger is a good predictive measure of warm ischemia for the actual heart.
Hey,
Next
Matt.
slide.
Hey, Matt, before you
Yeah.
go on, you just had a little hiccup, and you were saying that your warm ischemic time starts when the SAT is below 70.
That's for OCS.
Yep.
OCS, and then you also said pressure, but you glitched at that point, so I didn't hear what it was.
50.
It's 50?
50
Yep.
for
we do
NRP.
we do mean arterial pressures of 50.
Okay.
So this is our NRT, and by the way, when this talk was given, when I gave this talk last, we've updated it. So what we do is, this is our average age of what we've done here at Vandy. We're actually up to 27 now, so you can see that this hasn't been updated. This is with an N of 14. We're at 27 now, and so we've made some changes. The agonal starts at 70 or less than 50. We have wiped away the SATs of 70 for NRP because we don't feel that a pulse ox on the finger is a good predictor of what is going on at the coronary level. Mm-hmm. And so we do SATs. We wiped away the SAT as an agonal, and we've just stuck with a systolic blood pressure of 50.
Systolic,
whereas
okay.
in OCS it's 70% and a MAP of 50.
Yes.
Mean arterial of 50.
Yeah.
Okay.
Correct. So we everything was modeled off the OCS because they did so much work and they've done a really phenomenal job with organ preservation. And what we've done is we've tried to modify it as we get more and more experience with it. We continue to modify our parameters. Like I said, we've gone out on the length of where we'll go get one, and to be quite honest, we've actually made some tweaks and some changes of actually how we preserve the heart as far as the cannula type. Our next step is it worth, because there's about a 7% dissection rate on cannulation. Cannulating a flaccid aorta is not the easiest task. I've never cannulated at all, but we've got very experienced guys here, and it's just technically very, very challenging. So the next step that we're feeling that we make the change is we may put aortic cannula stitches in prior to aortotomy, stab incision for cannulation, just to have a more controlled. You actually have some tethering of the aorta. If you have stitches in, you can pull against something as they're popping that aortic cannula in. On a flaccid aorta, there's all they're doing is holding DeBakey's. The assistant's holding a DeBakey with one hand because the other hand's on the atrial cannula, and the surgeon's pulling with another DeBakey, and they're just trying to stab, put a cannula in a flaccid aorta with just really two pickups. Yeah. Yep. And so you can see our times. It's between 1 and 4 minutes. Average is 2, and that really hasn't changed. Even you think, well, you should be able to cut down on more experience. It really doesn't change. There's a fixed amount of time that it just takes to do these things. And you'll see in the slide, or you'll see in this video at the end that I have. We'll talk about it then, but you can see, it seems like it just takes a long time to get on, but really it's always less than 4 minutes. Next slide. And then these are our recipient characteristics. Once again, I'll say this is an N of 14. We're up to 27 now, and so the N is doubled. So I'm sure these scores and these demographics have changed as well. I don't think we've done a recipient over 69 yet, though. Next slide. And like I said, we've updated. We're up to 33. This was as of last night, so I apologize. I thought it was 27. We're up to 33. Of those 33, more than 17 livers were used. We know, like I said, we took 14 of the hearts when the slide was made. Some of the hearts were not good, but the livers were. So I'm sure we're above 35 on the livers used. Lungs we've increased as well, and like I said, all the other data is really irrelevant as it's not been updated. I apologize. We've done 4 this week.
Wow.
Next slide. And then this is the paper from our colleagues, my colleagues here, Dr. Hoffman, Dr. Shaw is our chairman, Dr. McMaster, Dr. Absey, and Dr. Trahanis are our team of cardiac surgeons that go out. And then we've got our esteemed colleagues, our cardiology colleagues, Dr. Lindenfeld, and all the other cardiologists that are, that follow the recipients. But this article was published, I believe, 2 months ago. So if you get a chance, it's Dr. Hoffman if you want to look that article up.
Yeah.
Next slide.
Oh, for sure.
And then the complications, you can see there's an intramural hematoma right there, and that's a hematoma, but it also dissected. Once again, once this happens, the cardiac team immediately backs away, and the abdominal organs are still perfused and recovered in a normal DCD fashion. Next slide. So it's funny, we get compliments after the fact on a lot of our organs after the NRP. We've had livers that start making bile while the surgery is going on the implant. It's because they've been hyperperfused and they've been the metabolites been washed out, and actually it's a more pristine organ than on a traditional DCD. And so some of the liver docs are saying these organs are immediately even in in the middle of surgery acting like a regular organ would on a regular, if you were going to do a liver resection, or you had to do something with a bile duct, a revision. These organs are actually actively metabolizing. The liver is actually actively metabolizing things while it's being sewn back in on a transplant. They don't see that very often, and so there's a lot of anatomical advantages. They're not in a big hurry because they get great dissection out while the donor's on pump, and literally they get good visualization. They get an hour, nearly an hour, to actually mobilize and get everything to tee up their explant of that organ, and so they've really caught on and really are more or less. This plays to the advantage of the abdominal teams as well, and that's just not through data, but it's also word of mouth. And a lot of these centers, they're not, a lot of centers aren't big academic centers that are doing liver transplants, and so they're not going to produce the papers that the academic centers, but word of mouth. We see these same people over and over again. They're just like, yeah, this is great, they're a little bit cautious at first because they're worried about jeopardizing their organ. But once they've even seen when the cannulation is not going well and they still get their organ, they realize that it's really no different whether the cannulation doesn't go well and they have to do a DCD as a traditional liver DCD versus there's a huge upside if we do get on pump you know, the 93% of the time that we're able to get on pump, their organs are better, and the process is just a lot smoother for them. Next slide. And you know, this is probably the thing I'm not going to talk about this so much, but there's really an ethical concern about this. DCD, these patients are all organ donors. They've signed the card. They've got the medical document in their in their will. But there is still an ethical concern that these patients are not brain dead, and so the teams that are taking care of them, they are a patient. They're an advocate for the patient. There's a formal timeout, just like on any surgery you would do, and the procurement team walks out, and those providers take care of that patient as well as they can within the confines of just withdrawing care. And there is some ethics about when you withdraw care, you're still giving meds to make people feel comfortable, just as you would while you were giving care to them. You're just removing a breathing tube is essentially what we're doing. But they continue to give meds, whether it be analgesic meds, and the real efficacy is are you giving where the discussion is how much analgesic are you giving, how much different medications, how much you're giving, and would you be giving that if it was in a different situation? And I'll leave it at that. We can have a discussion about that. Next slide. And we are, like I said, we've done 4 this week. It's oh, that's a great picture. They snuck that in on me. Yeah, that's us in the back of the van. Dr. Hoffman, Harry, myself, and Emily. That's the team. The resident is actually taking the photo. So they're not in there, but it's a team of 5 for us. It's 2 perfusionists, 2 surgeons, and a preservationalist, the air and ground transport team, and the institution where we're going. They provide a fantastic team with the OPO, and then back at Vandy, this has really increased our transplant program. I think last night's was 106 or 107 for heart transplant this year, adult only, and so it has really increased our volumes, and with that it increases the need for beds. Our nursing staffing is fantastic, both in the operating room and in the ICU team. It's just a team effort. Next slide. And so in conclusion, we're supporting a DCD patient. It simplifies recovery of the organs. It minimizes ischemia and maximizes actually organ perfusion, because we're hyperperfusing, we're washing out the metabolites, and we're optimizing for cold storage, unlike on a regular DCD. So a DCD NRP really does all those things. It has been shown, just if nothing else from the liver teams, as far as the structures, as far as strictures of vessels, it's definitely seen that. We're waiting for some outcomes paper to come out from our abdominal organ teams, but we know here from a cardiac standpoint, it is we've improved outcomes, and we have an increase in potential amount of organs for for these people out there on these lists. And really, that's the end game, is that we have, regardless of at the end of the day, we still have an organ mismatch in numbers of donors to recipients, and this is a way that we can kind of change the game and slide the scale closer to having a number of organs for the number of people that need those organs. I think that's finally, with the OCS and NRP with DCDs. I think both platforms are going to definitely have their advantages. The DCD NRP, I think regionally, you're able to get organs that that are really advantageous in a local area within flight times. And then when you use something like the OCS, greater distances and marginal organs that you're unsure that they're actually going to be functional, I think that really is the platinum standard on evaluating organ transplantation. We at Vanderbilt, consider ourselves, a high volume program, and we're going to continue to have both platforms because it's just more tools in our toolbox, and it's a specific tool for a need. It's kind of how we visualize it. And thanks for having me, Joe.
Dude, thank you very much.
Wow.
Who are these gentlemen?
So I'm gonna ask you guys. I know who they are. One gentleman's near and dear here to Vanderbilt.
Where'd they go?
Oh,
What'd you take it down for? Hold on.
hold on.
There
There
we
we go.
Okay, well, one's smoking. That's interesting.
So I believe he was at Hopkins. He started out at Hopkins. There's a movie about him. What is it? What the Lord Has Made.
So, why do you keep doing that? Okay. All right, so tell us who they are. I can't guess.
Well, so the gentleman smoking, I believe, is Blaylock.
Blaylock, okay.
Oh.
From Blaylock
And-
tossing, procedure, Is
Yeah,
that Charles Drew?
Shunt Pediatrics.
Who is it? Oh, that's what's the guy's name? Yeah.
Yep.
What's his name? Remember the guy that came up with the Blaylock tossing procedure? He was a
Yep,
he was
he
a
was a
scrub.
scrub.
He ended up getting an honorary doctorate. What was his name?
Now you got me. Now I had the name.
Vivian
hold on.
Thomas.
Oh.
Vivian Thomas.
Vivian Thomas. That's right. Okay. So it's and Blaylock didn't like him. They didn't get
He was
along.
his lab assistant. Because he was Vivian Thomas was doing things, in the lab, and all of a sudden he was like, "Well, doctor, I came up with this because, he was a lab assistant. He was a brilliant man, and so they were both, we actually have a Vivian Thomas Way here at Vanderbilt. We just named one of the streets after him on campus.
Outstanding.
Nice.
Outstanding. That's right. Vivian Thomas. That was his name. See, I got his name. But
did.
I didn't know it first when I saw him. I didn't realize that. Now, so why are they? So, they were at Hopkins. Where's the connection with Vanderbilt?
They both started off here,
Oh.
Oh, I didn't know that.
Hmm.
and then they went to Baltimore. So that, like I said, it's their great works were done at Hopkins, but they originated here.
I didn't know that. Did you know that?
I did not
didn't
know
know that. And you're right. There was that movie. I didn't see that movie.
Yeah, I haven't seen
Was
it.
it a good movie?
It's fantastic.
Oh.
I'm gonna have to watch it. Okay. So I'm assuming we have questions. Lots and lots of questions.
And we've got one more video. If
Oh,
David's
yeah.
got
Oh, yeah,
it,
the
I'd
video.
like to show that real
I
quick,
wanna
and then
see
we can get
this.
into
Yeah.
discussion.
Watch.
So literally, so we did the sternal incision, or he's finding the sternal notch, and unfortunately, this is about the time they realized that the sternal saw was broke. This was yesterday. We did a test run on the sternal saw, and when we came in after the family had left, and they're realizing right now the saw is not working.
And I can see
that's a real problem.
I can
because
see
once
the
again,
panic.
So he grabs a heavy mayo,
Oh, wow.
and he's like, "This isn't working." And our perfusion, we have sterile trauma shears that we use for cutting tubing.
Yeah.
And so we opened up some sterile trauma shears, and he was able to get through the sternum with some trauma shears.
Wow.
Not our best. Not, like I said, not our best. But we don't bring our own instruments. We bring our own circuits. We don't bring the medical instruments. At the hospital that we're at, we rely on. We tested the sternal saw, made sure it worked ahead of time. But in the time that we had left the room and came back, something had happened.
Wow.
And it wasn't working. So you can imagine, the cardiac surgeon is a little bit under because we should have just been able to zip through this chest.
Mm-hmm.
So, he's thinking this whole time, what's it going to be like?
And somebody's getting ready to say 30 seconds.
Oh.
Yeah.
Yeah.
And so he gets through, probably, I think it was 42 seconds was what it took him to get through there.
Wow.
Sternal retractor gets put in. The assistant, it's their job to open, and he's dissecting out. He finds the pericardial groove. Groove opens the pericardium. Now he's trying to dissect out the head vessels with his fingers and trying to get up high so he can get a single clamp on all of them in one motion. And he's really dissecting out. And so from now on is about the time that it's typical. This is how long. So there's this big curved clamp. He clamped the head vessels, and now they're gonna. He puts a little L-shaped clamp, like a little curved clamp, on the right atrium. Makes a little stab incision because it'll have blood pouring out of it if you don't have that clamp on it, and then if you lose it, it's underwater and it's gone. So as the assistant takes that cannula off, or takes the clamp off, he throws the cannula in. We get hooked up to the line. We immediately start to drain. He'll tell me drain. We put vacuum. We're draining. So now the right heart is not distended. The left heart is still distended at this point because it's not beating. And so you can see that she's got a sucker. Just get out of the way. He's making a stab incision, getting ready. She's going to hold up with a pickup. He's going to hold up with a pickup. Makes the stab incision.
Is that an EOPA?
Cannulates. He's going to put the aortic cannula, the aortic line up to it. It's full of air, right? Because there's no pressure in the patient. This is the other thing I really, really want to emphasize. So he has me bump up. We clamp. There's still the aortic cannula is full of air. So he puts a stopcock on there with a 60 cc syringe. He pulls back blood from the aorta to fill the cannula retrograde. Closes the clamp and tells me to go on. So some of the, the common physiology that we, take for granted. And so now we're perfusing about 2 liters a minute. And, now everything's calm and he's starting to grab stitches and he's going to start sewing cannulas in. But you see that the assistant, both her hands aren't moving. She's a statue. She's holding the cannulas. There's no purse strings. But some of the things that we don't think about, when we do a normal cannulation, we cannulate, all the time as perfusion. Not we don't cannulate, but we're part of that process. The whole, this is a completely different mindset because there's no pressure in these patients. There's a lot of venous pressure, no arterial pressure. Right. And so I just wanted to show you that, we got a great video yesterday. It was not, it was not designed to be without a sternal saw. And so even with that, that was a 3-minute and 52-second from skin incision, which you didn't see prior to that, to actually getting on with an aortic flow was 3 minutes and 52 seconds. And not having a sternal saw, that's fantastic. Wow. And the recipient's doing great this morning.
Wow.
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 Yeah, I'll tell you, I was really amazing at how you could see the urgency.
Yes.
But then once you were on, it was amazing at how it just like a light switch. He just
everything
switched
just
off.
calmed.
Yep. Yeah.
Yeah.
And that had to be hectic.
Perfusionists, that's what our value
that's our role.
Is that once I mean seriously, once someone else has done their job as far as cannulating, it is in our hands, and we, so primarily, Joey and I, last night, 60 minutes. The organs are they're turned around every 15 minutes. Hey, what's our lactate? What's our global lactate?
Mm-hmm.
And so all the teams are really relying on perfusionists, which I'd like to get into another discussion. After I want to talk about what the definition of perfusion and perfusionist is, because more recently I've had some interactions and I've gotten some phone calls about what the definition of a perfusionist is, and I'm a little bit concerned about what's going on there in our community. Liver and kidney teams are taking clinicians with them that are claiming to be perfusionists. And while they may perfuse an organ on a kidney machine or may perfuse a liver on a liver machine, they are not perfusionists. But they claim to be perfusionists. They're perfusing, so they're perfusionists. But the term, it's like calling a doctor a doctor. They may have a PhD, but when you go to a hospital and you want to speak to a doctor, you're assuming that that's a medical doctor.
Right.
They may have a doctor in theology, but they're still a doctor.
Right.
And so I'm seeing a lot of these people that in these huddles that we have, and they go around the room and they go, oh, this is Dr. Hoffman from Vanderbilt, cardiac surgeon, Matt Warhoover, perfusionist, Vanderbilt, John or Jane Doe, perfusionist from Kentucky, or perfusionist from North Carolina. And then, while we're sitting in the room, you go, hey, where did you go to perfusion school? Oh, well, I'm not a perfusionist. I didn't go to perfusion school. I just perfused. But they're being introduced and they're being sold to the room as perfusionists.
Wow.
Well,
And
that's
so,
concerning. And just for a point of reference, Matt, you were the president of the Tennessee State Perfusion Society. Are you still the president?
Yeah, we're actually we have a society. It's been inactive just because quite frankly, I've been pretty busy with the COVID thing, and kind of had a little bit of apathy for the. We haven't had a meeting in probably 5 years. Need to get back on that, but we need help from the whole community in Tennessee.
Right.
We just can't have one person or two people put on the meeting. So
Sure.
as you know, it's difficult to put on anything. You make it look easy, but it's not.
Okay. I understand. Thank you for saying that. That's very true. Yes. Well, the sign of a true professional is making the impossible look easy, or the
Right.
improbable. I won't say impossible. That may be a little excessive. But just like this team just did, getting
incredible.
this patient on bypass, that looked very improbable when the sternal saw did not work. And then you try heavy mayos and they don't work. And then you go, I know what to. Somebody said, use these. And it was probably you or one of your team that said, use these basically giant bandage scissors. I know it's going to work. These are the ones that they sell on TV where they cut pennies. You've seen those advertisements before, those scissors. I mean, that's a reality. And that's brutal. That was brutal to watch. I mean, it's horrible.
Seemed like it was
because
so long.
Yes. But at the end of the day, that's what a professional does.
Right.
Whether you're a professional sports player that makes a one-handed catch at the back of the end zone and is able to get both feet in bounds, or you're a surgeon who is trying to get into a chest of this terribly tragic circumstance. But, for the death of that patient, how many patients then got an opportunity to live? And the
Absolutely.
clock is ticking. This patient is deceased. This patient's not coming out of here. Or this person is not coming out of this. But you don't want to have done all of this and then have wasted all of those organs. And the fact that you were able to do this, and then you and your team being able to know
Incredible.
exactly what to do for the essentially reanimation and the correction of these patients' horribly physiologic deficits and derangements, and then for you to bring up, and the reason I brought the Tennessee Perfusion Society isn't necessarily because, inactive, active, whatever it is, but you have a vested interest in our profession and preserving and maintaining our profession, and you're bringing up something that's very serious, and that is people essentially are impersonating what it is we do, and that's a serious concern.
Absolutely. What kind of training do these people, are they just scrub technicians that are trained to do whatever it is that
Yeah, what's their medical background?
What do they do
Well,
normally?
You know what, I don't know, because where did you go to perfusion school? Because, you know, we are a small type, you know,
Right.
community, and you know, you may not know everybody, but you know, within a region, you've heard the name, or you know, or at least you know someone that they know.
Mm-hmm.
Once I asked that question, like, well, I didn't really go to perfusion school. I actually, you know, I actually perfused the kidneys, you know, whatever hospital they're with. The conversation kind of goes pretty cold. So I don't even know what their training is. I've had some people call from Maryland most recently, and South Carolina. The presidents of different perfusion groups call and go, hey, are you running into this? Because we're definitely running into this, and it's very concerning for their groups, because essentially what they're doing is, to your point, they're impersonating, you know, the knowledge base, and so what you kind of hit on something that I talked about with a couple of the people offline that have been calling about this, is that, you know, you as we as a perfusion group, as a community, know, you know, pressure, you know, pressure loops, and we know that, you know, what end organ perfusion should be. You know, we've got that training. They don't, you know, you don't, you know, unless you have that knowledge base. That, you know, many times that, you know, they go, well, we need to keep these patients are having levo put on. Well, you know, there's many times when I talk to the nurse, like, when you go to extubate, you're going to turn the levo off, correct? Because all levo is actually doing is actually increasing the vascular resistance, and you're giving it even less organ perfusion.
Mm-hmm.
And so trained perfusionists from a perfusion school know about those pressure loops, know about those vasoactive drugs. Someone that is, you know, whether it be a scrub tech, I don't even know what their background is. They may or may not know that. And when you're going to preserve an organ, you know, those things are important. And so you have to understand the full global scope of what's going on from a physiologic standpoint, just not how to run, you know, a machine that you put a kidney in and you're turning two different knobs.
Well, yeah,
You know the old adage, you know, we're you know, knob turners, pump monkeys. You know, that's all fun and games, and it's a joke, and you know, it's kind of funny. But the reality is that's not true. That's not who any of us are.
Of course. Well, you know, it's one thing to
and that
know.
separates us from anybody else.
Yeah, it's one thing to know how to do something. It's
Right.
another thing to know why you're doing something, and when that really matters is when there's a problem. You know, it's all easy when it's routine. It becomes much more of a challenge when you get thrown curveballs and you can't think far enough ahead to know what can I do to fix this so that we don't have a bad outcome. I mean, that's really troubling to me.
You know what's shocking to me is the other teams, the non-cardiac teams. I'm sure those doctors are aware what a perfusionist is and how they're allowing someone on their team to present themselves as that, other than simply, you know, you've probably been called a doctor in your white coat before, and you're quick to correct them. Oh,
Yes.
I'm not a doctor. I'm a perfusionist.
Oh, yeah.
Right.
And
Correct.
so the person doing the kidney perfusion or whatever should be quick to say, I'm a technician here to perfuse the kidney. You know, it's just
right, as
common.
opposed to a perfusionist. It's
Right.
common courtesy.
It's a common courtesy, and
Sure.
it's just honesty.
Yes, agreed. So,
Wow.
yeah, I know. One question, because we have actual questions about the topic today that we want to get to. And by the way, we've gotten Azerbaijan. How do you say that? Azerbaijan. And also from Greece, saying thank you very much for the amazing content and videos. I wanted to point that out to you. But did you have some questions? 'Cause I have a lot of questions.
You go ahead. I've got just a couple.
So on these, on these hearts especially, are there, when you clamp the head vessels, and I realize it's pretty fast. It's faster than I thought, but I was wondering about the hormonal neurologic effect on the organ when you clamp out the brain, because there is a lot of concern about heart transplantation in particular after brain death, and actually it is problematic from what I understand. What can you tell us about that?
So we have a very and it's not it's not a proprietary thing. We used a full spectrum of ingredients in our cocktail, if you will. Levothyroxine is one of our additives in our priming solution. So that is replacing. That's the T4 end product from the brain, and so we use that as one of our priming. We add a couple multivitamin vials that it's an adult multivitamin. It's two vials of that. One's a yellowish substance. The other's a clear. Has a laundry list of different ingredients in those. Those are all in hopes to replace end organ vitamins that are that have a lot of regulation from hormones. So the reality is that we're putting in a lot of drugs into our prime to offset some of the insults that we do by having an FD. So I don't know if you noticed, we don't have a blender. So we're taking direct 100% oxygen from the anesthesia machine from a flow meter. And so we have the capability of controlling sweep, but not FDO2 or FiO2, whatever you want to call it. So sometimes our PO2s are in the 500s and 600s. Well, it doesn't matter where you subscribe to, whether you subscribe to, for oxygen-free radicals, a demise or dying situation. Organs aren't necessarily, acting as they would, in healthy patients. So we use acetylcysteine, which is in our prime as an oxygen radical. So, it binds them. In addition to all, but so we're doing a lot of things with our prime to try to optimize and counter what really happens with death and with some of the insults that we do, like you say, clamping the head vessels. So we've kind of thought about it from a broad standpoint, from multiple different clinicians, from pharmacists to cardiac surgeons, intensivists, pulmonologists. We've talked to a gambit of people here at Vanderbilt. We've come up with a cocktail that we feel is a formidable opponent against all those things that we do.
Mm-hmm. So I had another question. Actually, I guess it's a two-part question. How high do you see the lactates when you first get on your first lactate, we'll say? And then the second part of that question is, do you try to achieve normal physiology, or do you try to get into an alkalotic state? Like, what are you trying to accomplish metabolically?
That's a great question. And so depending on the time of demise, we've lactate as low as 3. We've seen a lactate is greater than 50, first one.
Oh, could you say that again?
Could you say that again?
Greater than what?
Yeah, you're getting
hiccupy
again.
We've seen a lactate as low as 3, and as a high is greater than 15 because it won't measure any higher. It just depends on the length of demise, on how long the patient was down as far as warm ischemia to actual death.
Right.
But what we do see, I'm not going to say 100% of the time, but nearly all the time, we see the heart come back in a normal rhythm. We see the lactate trend at least flatten, if not go down. And we also, to your second part of your question, is we usually see a pH anywhere, we've seen as low as 7.04, but we turn it around always in an alkalotic state, usually in the 7.5 to 7.6 area. That's what we preserve it in right before the cardioplegia flush.
Okay.
Gotcha.
But we turn the organs into an alkalotic state. We get worried a little bit with sodium because the patient, depending on what events happen prior to them becoming an organ donor, a lot of injuries promote high saline high saline drips, try to minimize tissue inflammation. And then we turn around and our go-to is a bicarb to turn around a base deficit.
Yeah.
Usually do have a high end sodium on the sodium scale, if not, but on a high limit. We haven't seen any bad effects post-op with our patients that are receiving these organs when it comes to sodium.
Okay.
You
But
guys
it's
need
not
to,
uncommon for us to have a sodium in the high 150s, low 160s.
yeah,
Oh.
yeah. I mean, that's high, but not it's high, but I wish there was a way to remember. We used to use THAM a lot. I'm assuming you wish you had THAM, but you can't get it anymore.
THAM's hard to come by.
Very hard
Yeah.
to come by, but that was so much better than sodium bicarb as far as that's
Yep.
concerned. And I'm curious now. Once you get on pump, you stay on pump for a while before the transplant and everything else, right? Before you explant the organs.
Correct. So we're on between 45 minutes and we'll say 65 minutes of perfusing all the in vivo organ. And then once everybody's got their dissection taken care of, that all their vessels really looped and they've got good exposure and they're ready to go, they'll actually even insert cannulas into those and clamp the cannulas. The liver team, the kidney team, they'll have all their cannulas in. Literally, it's a really nice orchestra of things, and it's very calm and regimented, for the organ procurement, that part of it, because it's literally, okay, everybody ready to clamp, 1, 2, 3, everybody clamps, everybody hooks up, everybody starts flushing. I come off the ECLS machine, keep my my venous drainage open, continue to apply vacuum, and everybody does their thing. It's really well orchestrated on the back end. But the whole idea, everybody has to have their complement of, are you ready? Are you ready? Are you ready? Ready? And then they turn around. Are you happy with the blood preservation as far as are you happy with your pH? Are you happy with your calcium? Happy with your potassium? Are you good from a light standpoint? And once everybody has you don't want to waste any more time. You want to go ahead and proceed with the explant of all the organs. So usually between 45 minutes and 65 minutes, all teams, including the perfusate of the blood, is turned back around and we're ready to go.
Have you considered using, because being that you have the bicarb issue, the sodium issue, things like that, have you considered using high volume, like hooking a hemoconcentrator up to your circuit and using high volume CVVH with the bicarb based physiologic solutions like the Prismasol or the Prismasate or the Braun fluid or the next stage fluid? They all have their own iteration of this fluid, but you would have normal sodium. It has a bicarb of 32, and of course you could make the potassium whatever you want. So have you considered that?
So we in the very beginning we said, well, what we're going to do is we're going to bring a hemoconcentrator, because a lot of these patients are fluid overloaded. I didn't mention that we actually get a pre-op gas on the patient before anything happens. So as soon as we get there, we try to get a pre-op gas. we would like to have a crit greater than 25. If not, they will give the patient blood before anything happens. So usually our contacts the OPO and the physicians on site there, and they want us that they say we'd like to have a crit of 5 or greater, because dump crystalloid on top, we're looking closer to 21. The real problem with using a hemoconcentrator and all the ideas you just said, they're a fantastic idea. We've got two problems with that. One, we've got a fixed amount of time. Really, by the time we're able to get all that implemented, we're probably going to only have about 35 or 40 minutes of act. We'll be actually be able to physically do that, because the last 10 minutes, everybody's putting their cannulas in, mechanical manipulation of vessels. Our perfusion return, our venous return is quite poor the last 10 minutes. Because of manipulation. So, in addition, we are fully heparinized, and we're running a pressure. We're trying to hyperperfuse these patients. We're trying to run a higher pressure without having vasoconstrictive things. And so you can imagine the cautery is not necessarily used as judiciously as what I would say I would like it to be, because on normal procurements, you're not worried about that. So this is a new concept for a lot of the abdominal organ teams. So when they're cutting their dissecting, they're doing blunt dissection. They're not using a cautery for it. And we have 4 units of blood set aside in the, and I would say 75% of the time we use at least 2 units of blood. So from a volume standpoint, we don't have the volume to hemoconcentrate. Even as a zero balance, we don't have the time. 2, we don't have the volume to do that. We get these huge volume swings from manipulation of just the abdominal organs, just moving the intestines and trying to get exposure. There's a real pushing and pulling on the IVC and the vena cava.
Sure, absolutely, absolutely. Did you have some questions?
I have a couple questions. You actually answered one of mine about
Or
what.
I asked.
Yeah. Oh, yeah. You asked and Matt answered about
I
the
didn't answer nothing.
about what kind of pH you were going for. But so when we were talking about your numbers, or when you were talking about numbers earlier about just using the kidney procurements and talking about, if you just took 30% of that, it's additional 400 hearts a year that could be used for transplants. What's the current shortfall that's where people needing hearts and there aren't enough hearts available? Do you have any numbers on that?
Someone just gave me a website last night that I was unfamiliar with, but I think it's TNO. There's a website out there. I looked at it last night. I could look it on my phone right now because I made it a link. But I looked last night. So the DCD population of donors versus the regular brain death donors, it's 3 to 1. Wow. So there are 3 more DCD donors for every 1 brain dead donor.
Wow.
And so you can imagine that I think there's only 3 or 4, maybe 5 centers doing DCD hearts in the country. So you can imagine if there were, if there were people doing DCD hearts, there would be 3 times the amount of organs for people to choose from.
Yeah.
So that in itself right there is pretty telling in my mind. I want to say there was 15,000 donors last year, and I could be wrong because I looked at a number. It was 10,000. It was 10,700, 900. I looked at the site last night, but that could have been over a 3-year period.
Oh yeah.
It could have been over a 2-year period. There's a window. There's a sliding bar. That on this website, and I should know it, but I just found out about last night. But I haven't really played with it. But it's a national registry of organ donation.
Oh, okay.
And you can do it by region. You can do it by center. I would assume any transplant coordinator, our transplant coordinator knew about it because I asked her about it last night. She goes, "Oh yeah, that's what I look at." She goes, "Yeah, because you're always asking me, well, what number are we on?" She goes, "You can always look at it, and you can skew it by institution." So,
Okay.
I've got it pinged on Vanderbilt how many transplants we've done across all organs
Yeah,
Yeah.
here.
you're
So
so on
it's
the on,
that data it's a public knowledge.
Okay.
so is it safe to say, to your question, is it safe to say that there are in the current state a significant shortage of donor hearts for for patients that need a heart transplant?
Absolutely. I do remember an anecdotal paper saying out there that if we did DCDs, and OCS, this was in inclusion of OCS. I think it was a kind of an OCS paper, or a white paper, that we would be able to cut our shortage by 40%.
Oh, wow.
So there was a significant shortage, but inclusive of OCS, if we would use OCS, we could cut the shortfall by 40%. That doesn't necessarily even talk about the regular NRP.
Right.
Because and so I'm sure combined, we would still have a shortage, but not to the extent that we have.
Mm-hmm.
And I apologize not having that data.
No,
it's
that's
it's
all right.
fine. Another just real quick question. I know you touched on this about determining OCS versus NRP. So,
Mhm.
how is that? I know it's determined by distance and all of those other sorts of things that you said, but when you're actually, is a committee sitting down and determining, okay, this potential one came up, we're going to do it this way. Who's determining that?
So we have our a sponsor, or the sponsor who takes for the study, because it's not quite FDA approved yet.
Oh, I see. Yeah.
That's they're in. So our chairman of cardiac surgery, he's our sponsor,
Yeah.
and so he makes the determination whether we're going to do, whether we do the OCS, whether we do NRP, or just what mechanism of going and getting the organs.
Yeah.
He he also takes in consideration the implanting surgeon, that they talk about it, because ultimately it's responsible. Sometimes he's the implanting surgeon, but if he's not, they have, they talk about it.
I see.
Interesting.
Yeah, and then last thing, is there? Have you had? Because it seems like the hyperperfusion would be better, as you said, for all the organs. Is there ever been an incidents where you went in to harvest the heart, you're on pump, and then you determine that you're not going to be able to remove the heart, and that you leave the patient on hyperperfusion to help normalize all the other organs? Have you come across that?
Yep. In those 7% instances that we have that we don't get the heart, namely it's due to aortic dissection or aortic hematoma, but it also can be, remember, DCD, the OPOs don't get to run, not even sometimes echoes on these patients, because that is a TEE is actually a procedure that would not be indicated for the medical treatment of that patient, right? Because if they've got a head injury, there's no reason to actually echo them.
Right.
So a lot of times, it's very minimal knowledge going in what kind of cardiac they have, other than just age and just anecdotally what's their blood pressure and what's their heart rate. So a couple things, we've dissected the aorta before, got a huge hematoma, tried to fix it, and then got the true lumen, but because of the dissection ran retrograde towards the coronaries, we knew that we weren't going to take the heart.
Yeah.
So we've lost the heart, but we continue to perfuse for the rest of the abdominal team for that hour. We've done that a couple times. So we know the heart's no good, but we're playing team ball here, and that's what we do.
Right. Well,
The other thing is we've done where we completely do a, um, you know, a full run. They go to cut the heart out. They go to cut the heart out, and they look, and the patient's got a bicuspid aortic valve. Unknown, but we're not going to transplant a bicuspid aortic valve.
right.
So the heart, we just say no. Although we perfuse the heart for an hour, the heart looks great. They're not going to implant a bicuspid aortic valve into someone.
Right.
And then the third thing is that's why our age limit on the upper end of these DCDs are about 35. We've gotten in there and they go to, or even during it, they feel and there's a calcium deposit in the LAD. They can just see it.
That's what I was wondering.
And
I was actually going to follow up with that.
Then you go, early CAD in patients. You don't have a good history of what they have. These are patients that some event happened to them, and sometimes they don't even have any family history. They don't even know. There's not a good record of what's going on. They have a loved one, or on the back of their driver's license, they're checked for an organ donator. But so they don't have a family history. You have no idea. But once you get in there and you go, we're perfusing it, the surgeon feels, and the next thing you know, he's like, there's a huge calcium deposit on this LAD. And so, we make a phone call back, and they're like, nope, we're going to pass on this, but we continue with the procedure for all the other abdominal organs.
Right.
That makes sense.
Yeah, that does make sense. So that's all my questions. I was going to follow up with if you ever had to turn down the heart for something being wrong with the heart that you didn't know. So, of course, you covered that. So.
Yep.
Yeah, well, one of your slides said you had eyeball.
Yeah, looking at the heart, right?
So you're looking at it, and if it's not, whether it be something obvious like a bicuspid aortic valve or something obvious like a big calcific plaque on one of the coronaries, especially the LAD, you're looking at it. But are you also looking at how it reanimates and how it's contracting?
That's a good point, Joe, and I apologize. Yeah. So at the 45-minute mark, we actually come off the bypass circuit, and we actually fill the entire heart up, and we take a video, usually about a 30-second video of the hemodynamics and what the heart is doing, and we send it back to the implanting surgeon just so they know what the heart function looks like. That's important. I forgot to explain that. Wow. That's a great point, Joe.
Yeah.
So the implanting surgeon actually gets eyeballs on what the functioning heart would look like. Temporarily.
Yeah.
And of course they don't have levo, they don't have, dobutamine, dopamine, whatever inotropes that you're going to have. This is just cold turkey, come off, and this is what you get.
Yeah.
Mm-hmm.
And so, but usually, these organs are, 18 to 35 years old, and
they're pretty snappy.
It may not be generating the blood pressure that you want, but they're looking more on what the squeeze is doing, what the visual EF is doing.
Yeah.
Sure.
Yeah.
Sure. Absolutely.
And one other thing I forgot to mention as far as the eyeball test, we've also gotten in there, and because maybe it was a rollover car accident, or it was blunt trauma, motorcycle, like it is. You get in there, and then all of a sudden, you'll see a huge hematoma on the heart, or even a laceration. And so when they go to take the pericardial window, or they cardium and expose, instead of just seeing pericardial fluid, it's bloody.
Yeah.
And then you look on the right atrium or the right ventricle, and there's a huge, laceration, or a huge bruise.
Mm. And that's it.
Well.
You're going to reject that.
We've
that'll
had
be a
that
protection.
as well.
Yeah.
Yeah.
Huh.
Like so, a big cardiac contusion would be, or cavitation, a cavity rupture is going to be, you're done. That's it.
Well, right. Yeah, and it's usually not a cavity rupture, but we have seen huge hematomas on the heart from a blunt trauma.
Wow.
Wow.
Yeah, big time. Well, very good, Matt. This was excellent. I could go on for much longer, but in deference to your time and everyone else, I have to just ask, can we do this again?
Yeah.
And do a part
Absolutely.
2 of this.
Yeah.
And I have said it, I don't know how many times now, Tammy and I and Min are coming to Nashville. We're going to do a program from there. And we've got to do it. You know, for us, I don't know, I'm assuming you're seeing the same thing. That was something I wanted to mention, is that it's surprising to me how high your heart transplant volume was able to stay through COVID.
Yeah.
In the beginning for us, we were really, no, we don't do transplants, but we were dropped way off on hearts. But then it has roared back. And even during really the time when we had so many patients on ECMO in the ICU, we were doing more hearts than we had ever done. We were doing, you know, we usually do 3 to 4 a day. We were doing 6 and 7.
Well, in a couple days, we had 10 or 11.
Yeah.
That's
hearts.
A lot more.
Yeah, that's
for
a lot
us,
more.
for a
yes.
team our size. That's a lot.
Yeah, it was insanity. It was insanity. But, you know, our volume has really cut, our number of patients, we only have currently 1 patient remaining on ECMO.
For COVID.
For COVID ECMO. And in the local Houston area, we're down to 14% of critical care space occupied by COVID
But
patients.
that's really changed just in the past, I don't know, 15 days,
Yes.
maybe 20 days, because just a few weeks ago, we had quite a number of patients still on ECMO for COVID.
Yes, we went from like 11, actually 12 when you think of the other hospitals, the outliers that we get, and we've put a couple in and got them transferred right away, so that helped us a lot. But we went from, you know, 11 or 12 to 8 to 6 to 4 to 2 within a matter of 10 days.
It was 10 days.
Just
so
dropped right off.
We see the same thing. Big drop off.
Yeah. We're no longer, you know, either decannulating or someone expiring and then cleaning that circuit up and just rolling it to the next room on the list. So that's a good thing.
We actually have put some equipment away. And, you know, and it's interesting because I could bring this up to you, but Tammy and I recently had a conversation with a hospital, and one of the things that I said, which I was, you know, quite serious about, is that Joe, have miscalculated now 3 times about the end of this surge of patients that we were going to get with ECMOs. And I don't plan, if I plan on miscalculating the 4th time, it's going to be because I overplanned and it didn't happen, as opposed to using hope as a strategy, which was just not smart on my part. But I wasn't sure. I really believed after the 2nd one, I was confident it was over. And then the 3rd one hit us even worse than the 1st one or the 2nd one. I can only assume now that a 4th is coming, and I have to prepare for it at this point in time.
I think that's a smart bet. I think we'll see what Thanksgiving and the Christmas holiday is going to bring, but I ain't worried about that.
Okay, well, I don't feel alone then, but I'm working diligently on solving this as an issue, because it really did break the morale of the group, the people in the group. This was very, very difficult. It was challenging for me, but of course, when you're in the thick of it, it's kind of like the boats dropping you off at Normandy. You can't stay on it. You have to get off, and you have to run across this beach.
Yeah.
You really don't have a choice, and I felt that we were basically in that situation. And as many times as I tried giving words of encouragement, they were, in essence, impotent to the reality of the situation. We have been beaten as a community.
True.
Yep, I agree.
I believe so.
Well,
final thoughts?
Well, thanks again, Joe.
yeah.
Thank you.
Matt, I don't know if I'm going to just say this every week, but that was really incredible. Probably the best talk that you guys have given. So I really enjoyed it. Thank you very much.
Exactly. And after this program's over, I'm going to tell David over there, best show ever.
Yeah.
That's what I always say. Except your internet connection today wasn't good. You kept drifting in and out a little bit, but that's okay. We have voiceover, so we'll just fill it in. Hopefully, it'll be correct.
Sounds good.
All right.
Well, thanks again, Joe.
Thanks,
Appreciate
Matt.
it.
Bye,
We'll see you
guys.
next month.
Yes,
All right,
sir.
Have a
Bye-bye.
great day. Bye-bye.
Could we take a 5-minute break, please?
Sure.
That was a long session.
That was so good.
That
That
was
video
awesome.
at the end
It was awesome.
incredible.
That video was, yes, we're likely going to get flagged, and
Yeah.
they'll put a content disclaimer on it or whatever. But no, that was
incredible.
That was awesome. I mean, that's real. That's
Yeah.
real. That's not just some theoretical nonsense that we talk about all the time. That was real.
Well, and I love that it wasn't their best
Yes.
perfect. It was them problem solving in the moment, and you could actually feel the tension
I could.
in the room, and then you felt it just
I know.
calm. It was
As soon as
incredible.
they-
And that was a under 4-minute video,
Yeah.
and we had all of that.
Yeah.
Yeah.
It was amazing. I mean, really to watch the surgical team watching them because they're under the gun,
Of course.
And I say this all of the time. Perfusionists, us, and whether it's even surgeons, anybody in the cardiac theater, whether it be the assistant, whether it be the scrubs, whether it be the circulator, whether it be the perfusionist, anesthesia, it doesn't make any difference. Although I put them last for obvious reasons. But I know, everything's anesthesia's fault, right? Everything that goes wrong. But no, at the end of the day, all of us are performers.
Mm-hmm.
Our audience is ourselves, but you can't find a worse critic
No.
than the very people you work with every day. We don't do a lot of backslapping and congratulating
Right.
and positive reinforcement. We are held to a tremendously high standard, and we are brutal on each other when we don't perform at the level that we are supposed to be performing at.
Sometimes it's not even the level you're supposed to be performing at. It's aiming for perfection,
Yes.
for the perfect case. I mean,
Yes.
I go into every case I do with that mindset. Today's going to be my perfect case.
Yes. Yes.
So I'm sure that's the same thought most people have.
Every case that I ever do has been the most perfect case, just like the show that David's doing today. Every
All
case.
right.
But we're performers, and we are constantly, we are watched. Everything we do is directly or indirectly, but definitely observed.
Yeah, and often judged.
Always judged. I will take often and change that to always. And not for the faint of heart. Heart surgery and high-level critical care management of very, very sick patients with all of these very exotic and technologically advanced therapeutic modalities is I say it all the time, it's a full contact sport. Mm-hmm. Absolutely. Okay, so is that okay with you guys? Can we take like a 5-minute break?
Yes.
Okay.
Okay.
Thank you. We'll be back in 5 minutes. 5 minutes, exactly. So it's 8:28. So at 8:33. Okay, let's go. And welcome back. That's right, everybody. And now it's time for the Tammy Sparacino Journal Club. What's up? Everything okay? Share the screen?
Yeah, I haven't done it yet.
Oh, okay. There, you have to share the screen. No, you have to do it like this.
Okay.
Do that,
Oh, yeah.
and then hit screen mirroring. And then you have to pick Joe's iMac.
There we go.
Yeah, and then once it does that, so while you're doing that, and then you have to click off of it. So anyway, Tammy Sparacino Journal Club, welcome back. I missed this because it came via Facebook. I look at YouTube, and Magic is looking at the Facebook and the Twitter. But Robert Parchman, I don't know if you're still on, Robert, but I'll send Matt. Actually, you can probably reach out to him yourself, but I'll send Matt a message. I apologize for having not seen this and asking about the 2 docs that you got from Vanderbilt. Glad you're doing well. It was so good to hear from you. I haven't talked to you in forever. Hope everything is going well with you up there in Shreveport. And then also we got from Australia. I don't know who it's from, but it's I can't. Huh?
Don't do it, he says.
I'm not going to try. I can't say the name. But thank you very much for an excellent talk. That's to Matt. Very interesting, and I'll make sure to pass that along to him. So I'll send both of these to Matt after the show, so I apologize for that. Okay, it's time for Tammy. Tammy Sparacino, it's yours.
Okay. Welcome, everyone. Hope you are staying with us after that wonderful talk from Matt at Vanderbilt. Today for our journal club, we are going to be looking at an article published in Perfusion Journal about a practical technique. The name of the article is the technical implementation of the percutaneous thrombus aspiration using the AngioVac system. It's by Benjamin Haupt and his colleagues.
Yeah, you got an easy name. I've seen you struggle too.
Oh, there's some words in here that I'm going to struggle with today. Well, I'm going to hope for the best. Okay, so abstract. Their objectives, the AngioVac system provides a method for minimally invasive percutaneous aspiration of thrombus formations originating from the central venous system as well as other solid matter such as pacemaker lead vegetations and right atrial thrombi. Their methods, this is a retrospective observational study. It describes the initial experiences in 52 adult patients with the AngioVac system, focusing mainly on the development of an extracorporeal circuit to improve safety, usability. The results, mean patient age was 63 years old. They had a range of 23 to 86. 22 patients were female and 30 were male. The indications for the percutaneous aspiration were lead vegetations at 69%, right atrial thrombi at 17%, and central venous thrombi at 9%. Pulmonary embolism at 3.8. Successful aspiration was performed in 44 of the 52, with partial success achieved in an additional 5 patients, and failure to remove the vegetations occurred in 3 cases. Their practical experience led to the installation of a shunt line for recirculation and the implementation of safety features concerning air handling. They're all, which are all employed into a minimally invasive extracorporeal bypass circuit. Initial test monitored the level of negative pressure according to the differences in flow and access sites, but that data still needs to be validated on a larger scale. And we'll get into the conclusion as we go through here. Okay, so the reason why this paper was published, obviously they wanted to have a look at they wanted to look at a patient population where they have used the AngioVac and the successes with that. But also because most of the studies, according to these authors that have been published about AngioVac, had a much lower patient total patient count, and so they wanted to do something that they could look at a little bit larger number. their problems to be solved, merely to see what they can do to modify the extracorporeal circuit to make it safe and easy to use. And we'll get into their methods and procedures. They've got some great diagrams in here, and that's what we'll start with. So you can see here that they have, if we go ahead and look at starting here for the outflow, you can see that they have a cannula coming out here.
No, we don't see what you're doing.
Oh, you don't?
No, you have to. So if you want to highlight, if you want a laser, push and hold.
Oh, that's what I wanted.
And the pen, that's going to write.
Oh, I didn't want to write. Okay.
Right, so just use your finger.
Oh, yeah. Okay, thank
Just
you.
push
I don't
and
know why I
hold.
can't remember this.
That's
okay.
okay.
So we'll start here, and you see this is the flow of the circuit. So it runs through a bubble detector, then into the trap that actually will catch the particulate matter, but it also acts as a bubble trap. Then it runs through an occluder into the centrifugal pump, out here into a flow sensor, and then back into the returning cannula. Now you'll notice that they've got some, they have a shunt line here. Oh, no, there we go. Hold, there we go. They have a shunt line here that is not in use during the case, but it is available for de-airing purposes if they need to do that. As far as safety, what they're looking at is they have their oh, good Lord. There we go. They have their bubble sensor here, and if a bubble is detected, then automatically this occluder stops flow, so that they're able to then assess the situation and see if they need to, how they need to evacuate the air. And you can see that they have a syringe on top here to be able to do that if necessary. All right. I think that's everything there. Very nice diagram, I thought. Okay, this is just a picture of the AngioVac cannula. If you've never seen it, you'll see it has a...
I think I have one.
Yeah, you probably do, because we've done some demos here. But just for the sake of this talk right now, you can see it has a flared tip so that it's able to grab onto the thrombus and be able to then, with the vacuum, suck it through.
It acts like a funnel.
Yeah, acts like a funnel.
And those are called the pedals.
Oh, the pedals.
And they flare out to create the funnel effect. So as the flow, as you're trying to engage with the whatever you're trying to remove, the unwanted intravascular material, it tends to pull it in that design. So that's why they have that.
Oh,
and
okay.
you expand those pedals with a syringe at the end of the cannula, and you can see the balloon. And so normally those are flat. Those are just they're not expanded.
Okay.
So you can put it through the sheath, usually
Yes.
a dry sheath.
Yes.
And then once you're where you want to be, you add air to that, and it opens those pedals up to form that conical or funnel shape.
Yeah. Okay. Here is just their safety features showing how they implemented them on their AngioVac circuit, and we kind of went through these already, but
that's a levodopa trolley.
Yes, that is what they use, and they use the Revolution centrifugal pump, and then the filter is made by the bubble trap matter filter is made by Terumo. All right. And then here's just a wide shot of it, and you can see that it is indeed on a trolley. Okay, and their last diagram here just looks at negative pressures during the variations of blood flow. So the blue line is their shunt line, and then they have the red for the femoral vein, and then the green for the jugular vein. And as you would expect, negative pressure increases with increasing flow. Okay, so let's get to their conclusions. The AngioVac system, as a tool for eliminating thrombi and lead vegetations, appeared to be safe in this initial experience. Additional safety features to improve air handling can be implemented and shunt lines enabled for periods of procedural breaks without interrupting the internal circulation. Further studies focusing on patient outcome parameters will improve knowledge about the long-term results of the mechanical percutaneous thrombus aspiration.
When was this written?
This year.
This year.
Mhm.
And from where?
Let's see, where were they? I have forgotten because I have another article we're going to talk about. They are in Germany, yes. Yeah,
Okay.
they're in Berlin. Yeah.
Okay, interesting.
Yeah. Okay, so I know you have some experience actually using the AngioVac. I have not had any personal experience in that, but I'm going to go ahead and just talk about
Yes,
a case
please.
presentation, and then we can get into that.
Absolutely.
And you can
Whenever
probably
you're-
elaborate a little more.
Whenever you're ready.
Okay. So this is actually a local Houston area online cardiovascular journal called the DeBakey Cardiovascular
Igor Grigoric? How long ago was that?
That's
Because he's not at DeBakey and Methodist. He's at Memorial.
no, this was published this year. It was a collaboration, I believe.
Oh, wow.
Yeah,
Okay.
this was published this year, and so it's very timely.
And
So
Carr?
yeah,
Mhm.
yeah. So some of our local colleagues were involved in this paper, and it's actually a really nice case presentation. So it was done at Houston Methodist in the Texas Medical Center at the DeBakey Heart and Vascular Center, written by, see, I told you I had a name,
Angelo. Just say Angelo.
Okay, by Angelo and his colleagues. So this is the percutaneous thrombus removal in a COVID-19 infected patient with a pulmonary embolus. Okay. Abstract's kind of long, but it's pretty interesting, so I'm going to breeze through it, but kind of highlight some things. We present a case describing the use of the AngioVac system and the Sentinel cerebral protection system in a patient with COVID-19 who initially presented with a large, deep vein thrombus in the left lower extremity complicated by a pulmonary embolism. Although he initially improved with systemic alteplase, which is it's like a TPA type enzyme.
Okay.
He later developed a second large clot diagnosed in transit to the right atrium. Within 12 hours from the initial thrombolysis, the large clot wedged across incidental PFO, the atrial septum, and the cavotricuspid annulus. We emergently performed a percutaneous clot extraction with preemptive placement of the Sentinel in anticipation of the cardioembolic Thank you. Cardioembolic phenomenon. A large, greater than 10 centimeter clot was extracted without complication, and the patient was discharged home. The combined use of...
Are we seeing the same thing?
Yeah, why? Where are you?
I'm just curious. Is this the same? Okay, I'm sorry.
I'm reading
I'm
exactly from it.
Sorry. Okay, I'm sorry.
Okay.
I lost it.
I told you
Okay.
it's kind of long, but
Yep.
it's very interesting. The combined use of the Sentinel and the AngioVac in this case suggests a potential role for percutaneous treatment of severe and consequential thromboembolic disease, especially in patients with a PFO, and they may be considered as an alternative and less invasive option in patients with COVID-19. While cerebral embolic protection devices are approved for and widely used in transcatheter aortic valve replacement procedures, there is a theoretical benefit for using them in percutaneous thrombolectomies as well. Okay, so here's...
So are you familiar with the Sentinel?
Yeah, I've seen them in TAVRs.
You've seen it, right,
yeah,
for TAVRs.
yeah, yeah.
For the, you want to, just in case people don't know what it is, you want to elaborate a little bit on it?
You can elaborate on it.
No, usually they put it into the radial.
Yeah.
And it's these two cone-shaped nets, one that goes in the right carotid and one is positioned in the left carotid, and it's used for that purpose, for trapping
So
any
I just knew it was in the carotids and it catches anything that might migrate up.
Yes.
Yeah. Okay, and I'm going to have actually some images about that.
Oh, cool.
Okay, so case presentation. This was a 44-year-old male, COVID-19 positive, presented with syncopal episode, hypoxic, oxygen saturations in the 80s, tachycardic, 140 beats per minute, mildly hypotensive, 101/63. He had angina. He was dizzy.
Dyspnea.
Yeah.
Short of breath.
Yeah, yeah. Oh, yeah, sorry. Short of breath and history of type 2 diabetes, hypertension, dyslipidemia, and obesity. Lactate 4.7, creatinine 2.4, troponin 0.19, large saddle embolism, COVID pneumonia, placed on a non-rebreather mask at 15 liters per minute, 100% FiO2, treated with dexamethasone, remdesivir, and 50 milligrams of alteplase. Following the treatment, the lactic acid normalized with thrombolytic therapy with heparin, repeat TTE, large clot wedged across the interatrial septum, surgery option eliminated due to hemodynamic instability, expedited right and left atrial embolectomy, was intubated preemptively. The sentinel was placed, a 19 French Biomedicus inflow cannula, 25 French Biomedicus outflow cannula, ACT greater than 300 was achieved. AngioVac cannula was guided into the right atrium. There was an organized clot that was retrieved through the PFO.
Wow.
Optes vena cava filter was placed. PFO was closed, extubated within a few hours, transferred out of the ICU, and discharged a few days later on room air and full anticoagulation. All right, so here's some images. So here, this figure 1 is the large saddle pulmonary embolus. The arrows are indicating where it's located. And this was obtained in tomography angiogram of the chest axial view. Okay, and then this one is a picture of what it looks like when the sentinel is placed. And if you've done TAVRs, you're probably familiar with this image because it's up on the the screen while we're kind of waiting around and they're getting everything going. So the sentinel is made by Boston Scientific, and this is has a proximal basket in the brachial cephalic trunk and the distal basket in the proximal left carotid artery. Okay. Figure 3 is a TEE of the AngioVac system cannula. That's where the yellow arrow is. It's retrieved back into the right atrium across the PFO. The left atrial portion of the clot, which is the X, is visualized as the right atrial portion of the clot, which is the star.
Wow.
Yeah. Okay, so here's a combination. So in figure 4, the TEE shows the negative flow is being applied using the AngioVac system, and the inflow aspirates the clot into the retrograde fashion into the right atrium across the PFO. Microcavitation is seen in the right chamber on the leftward interatrial septum in B, and then post-clot extraction in C. Oh no, B is post-clot extraction. Sorry, C is the extracted specimen. It's pretty big.
Yeah, so they went into the right side, went transeptal.
Yes.
Across the atrial septum, got the clot out of the left atrium.
Yep.
Pulled
it into
across,
the right.
Back across the PFO.
Yep.
Out.
Yes.
And then so you got the left side cleaned up. The reason the guy was having syncope was he was throwing clots.
Yes.
Lucky he didn't have a full-blown stroke.
Exactly. Exactly. So their conclusions, the combined use of the Sentinel cerebral protection system and the AngioVac in this patient suggests a potential role for percutaneous treatment of thrombus in transit. This is especially important in the context of the COVID-19 pandemic, which is generating a large number of patients with thrombotic complications who may not be eligible for surgery. The use of the CEPDs may provide additional protection against catastrophic neurologic sequelae.
Sequelae.
I told you I had some words.
Sequelae.
Yep. Sequelae in these critically ill.
Bad things that can happen to you.
Yes, in these critically ill patients. That's it.
Very good.
Those are my slides.
Excellent. That was very, very, very good. Could you please go back to your slide of your original diagram? So I have done.
Oh, in the
yeah,
actual article
very, yeah.
review.
So I haven't necessarily
This
done, that one.
Okay.
Because I'm going to just, from my perspective.
Because you've actually done it.
Yeah, I've probably done. I mean, I can't say I've done a whole lot of them.
You haven't done 52.
No, probably close to 30.
Yeah. Oh,
So
pretty good amount.
Pretty good number.
Yeah.
It's interesting too because we had a run of them. We were seeing so many of them, and then all of a sudden it kind of dropped off. And we're seeing. I think a lot of people have adopted for a lot. Well, you can't use it on everything, but I'll kind of get into that. But the penumbra system, which works pretty well. He's doing a lot of PEs with it.
Yeah.
And being very successful with it. I don't really think the AngioVac is a good system for PE because it's much bigger, much harder to navigate.
Yeah, it's hard to get around.
Yeah, it's a little more difficult to do. But of course, I don't think the penumbra is a good. Of course, I'm not positive, but I'm not. I don't think it's a great system for lead vegetations and things like that. In this
but we're not involved
case,
in that type of system. That's
right. They just pull it back, and you lose the blood. It doesn't have a circulation associated with it like this does. So I mean, they're very different systems. I think both have utility. I just think that it's a matter of using the right tool for the right patient. But that just depends, and I can't say I'm an expert on that. But this particular system that you're looking at here, I would absolutely not recommend. And I'll tell you why. So
is it the interruption?
Yes. So think about this from this perspective. I mean, and this is what happens. This is why you need a perfusionist, okay? This is one of the things that
why
Matt
you
was
don't
just
need a
talking
fake
about.
perfusionist?
Yes.
Yes.
A quasi-perfusionist.
Oh.
Because if you pull the cannula out, you're going to suck air. You can get, if it's inside the blood vessel, you get some cavitation, but you're not going to get a lot of air. But think about it, if you were to capture that clot in the left atrium, you have it, and for some reason you have a bubble come through, and it shuts that pump off. Automatically.
It's going to let go of it.
It's going to let go of it, and you're going to lose it, and it could get far worse than it already was. So that bubble trap is pretty effective. You would have to have removed it from the entire body, disconnected it.
You'd have to have a massive air.
Yes, to
amount
deprime that.
Yeah.
In that circumstance. So, and having that shunt line. I mean, all of that to me is making what should be a very simple procedure much more complicated than it needs to be. So, but the device really does. I mean, I've had some really good success with it, but I've also seen situations where it failed miserably, but not because of the device, because of operator error. And a surgeon that's not here anymore, I can very briefly tell you that we had a patient who we were removing like almost a calcified clot out
so
of
it was stuck to whatever it was. Yeah.
Out of the tricuspid valve, and it's not really designed for that, but you can do it. And they were trying to use it, but they were doing some other stuff, and they didn't turn the AngioVac on. And I saw a chunk of this material.
So they're maneuvering with it, but they hadn't yet started the negative pressure.
Correct, and that's the worst thing you can do. And anyway, that patient, they lost it. They sort of blew it off, and the patient ended up in the ICU with a big PE from that, and they died. So there's a lot of it's not just it's a very simple thing to do, but you have to use it right. You don't ever go near what you're trying to get to until you have really good flow. You want your flow up so that when you engage anything, it's coming out. You don't want to just knock something off.
Something about that. So I won't stop you there. You can keep talking, but they did talk about their flow a little bit, and I wanted to wanted to read about that.
Well, while you're doing that, can I throw up some different slides?
Oh, yeah, sure.
Do you mind?
No, I'm all
okay.
done.
So that was very good. I mean, I want to continue to talk about this. So let me, here, let me go here. This is actually, these are my slides. Actually, let me bring up Min's slides too, because Min did a talk on this very topic, as a matter of fact. Where is it? Where did it go? Let's see. Say something, do something, because I can't. I'm having a hard time here.
Well, I thought it was really interesting. I've been a little disappointed that I haven't gotten to do one. I haven't gotten to see one, but we haven't had any.
No, I know. I'm disappointed in that. I don't know why. I mean, they just sort of disappeared.
Yeah.
Okay, so are we still doing, showing the slides? You can throw those slides up.
Yeah, there's
Here.
the slides.
This is telling me I want to quit applications. No, I don't want to do that. Okay, so we're showing slides now. So I think these are, these were Min's slides, but they show how common DVT is, and of course with the COVID we have
even
seen
more.
Yeah, and we've seen both ways, right?
Yeah.
We've seen hypercoagulability and PEs and clots and DVTs and all that kind of stuff. We've also seen, coagulopathy, hypocoagulable situations where patients just bleed.
Won't stop bleeding.
It's just unbelievable. But anyway, there's 275 deaths per year from PE. Which is quite a bit, and usually it's it starts out somewhere, right?
Yeah, it starts somewhere.
Right. Who's at risk? Of course, this is talking about that. I think you have to add COVID to this, but obviously sedentary, pregnancy, trauma, post-surgical, patients that are obese have varicosities. 5 to 8% of the U.S. population has one of several genetic risk factors, an inherited thrombophilia.
Yeah.
And so you have this increased coagulability. Other uses, tricuspid valve vegetation, we've seen that. Of course, IV drug abusers frequently have that.
Yes.
Dialysis patients can frequently have that, not related to their bad lifestyle, but just their horribly bad luck. Infected catheter thrombus, vegetation and thrombus of the aorta, because now this device is now, I think it's approved now for
it is.
Left side. So you can go, as you saw in this particular case, they went transeptal, but even if you had a left atrial thrombus, like for example, you get a Watchman done and you don't get a really good seal, and you have clot growing on the outside of the Watchman, they can go in and evacuate that by going transeptal into the left atrial appendage, clean that out,
No kidding.
and do some, I think, repair in there so that they isolate it better and it doesn't become a recurring problem. Safely removing occluded IVC filters, another good point. Right atrial clot, IVC tumor, another thing that renal cell carcinoma, and others. It is big, it is expensive, but it's a lot less expensive than surgery, okay, no
for sure.
question about that. Let's see, that's the system. You can see here they don't have any of that stuff that you just showed.
Well, and even when we've done a demo here, we didn't have any of that.
Yes, and here it is in operation. There's some clot. These are our cases.
Yeah, will you go back?
Yeah.
I want to see. So we were using, what kind of system is that?
This is the bag was just used to drain it.
Oh, okay.
It was a Biomedicus.
Oh, okay, Biomedicus.
Yeah, it was just a Biomedicus. And there you see some stuff there. There's some stuff there.
Yeah, see it.
There's some stuff there.
Wow.
It has the capability to remove a lot. Now
That was
here,
a lot.
what you see, and I'll show my other diagram, but here you see the, in this particular circumstance, you see it's coming into PA, going into the collection canister, which is where that has the filter to trap. It's basically the material trap and air separator, basically. Here's the pump, okay, and you have a secondary pump coming this way. So they wide it here. That you can basically clamp this off. You're going into the femoral vein, but you can get oxygenation by, now it's Y. So here you have it, just a closed loop system, veno-venous. Now you see, if you clamp here and open this up, here's your ECMO pump through an oxygenator into the femoral arteries. So if your RV craps out on you and you have access, but you need systemic circulation, you can do it this way. And I have my own way of doing it.
Yeah.
I can show you what we did.
Yeah.
And there's Dr. Ramchandani. This is actually, this is his slide. And these were some of his samples as well. So they were doing this down in the medical center. He gave this talk at the New Orleans conference in New Orleans. I think we were at the Roosevelt at the time.
Yeah.
But he has a lot of experience with the use of this tool, this device. So let me.
I still really want to see it.
Yeah. So let me show you this if I can. Yeah, it's really a cool. I mean, it's.
I remember seeing
it. We were doing a case. We were Matoyer. Dr. Matoyer was giving a lecture on this very thing, and I was here. David was here. Magic was here.
I was here.
You were here. Yeah. And he calls me up and says, "You're not going to believe this." And I went, and we did an actual, he had an emergency AngioVac of a big mobile right atrial
Yeah, because
thrombus.
remember, I didn't have any experience, so I couldn't leave the webinar to go with him. You were supposed to be giving a demo, and Mike and I had to do the demo.
Yes, and it was a disaster.
It was a disaster.
It was a disaster.
We had never
That's what I
practiced
heard.
it.
Yes, exactly.
Yeah,
it was
Mike was here
It was
too.
a disaster.
We
and
refilmed it though. It's nice
exactly.
on the library
It's much better now. Yeah, this is Mins. Okay, so yeah, so I don't know if that video works. So there, you see that big clot. Look at it flopping from the. So if you look at the
it's
top
in and
left,
out.
that's the right atrium and then the right ventricle, and look at it flopping back and forth.
Yeah.
That is just an amazing video.
It really is.
And this was actually the case. This is the case that I left to go do.
Incredible.
Yeah,
because Min gave his talk later.
Yeah.
Yeah.
And then there's just another view of it. I don't know if this is a video. Yeah. So you'll be able to watch it. Look at it.
Oh, yeah.
You see it going through the tricuspid valve.
It's incredible.
Look at that. That was just awesome. That was awesome. Let's see. And so this is what we did. So that has a big reservoir. I don't think that's a good idea. That was from the extrapleural circulation. This is the one that we did. Here it is.
When you left?
This is the circuit that we created. And I'll kind of show you what we did.
Okay.
So this line here is this was the AngioVac catheter itself. So we're going to go into the right IJ because we're going into the right atrium to get this big mobile thrombus that's flopping back and forth. And here we have the system that goes through the filter where it traps it, comes down. The pump is down here, so we're drawing the negative pressure this way, and then it's going back into the femoral vein. So you basically have no change in hemodynamics because it's a closed loop until you lose flow. When you lose flow, it doesn't make any difference because it's caught the clot.
Yeah.
And that is the point. That's the most dangerous point. You don't want to turn it off or the thing will float away.
Yeah, and you can tell you have the clot. I remember reading this in the article.
Your flow goes to zero.
Well, and they said you would feel a large vibration in the outflow.
Chatter.
Yeah.
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 Exactly. I mean, it's pretty dramatic. It goes, and
Yeah.
you have it. I mean, you know you have it.
You know you have
And
it.
at that point in time, don't turn the thing down.
Yeah.
Just keep it, and sometimes you actually have to go up a little bit.
Yeah, to
and
get a
let
little
it-
more negative pressure.
And they call it toothpasting.
Oh, yeah, because it's just pulling it through bit by bit, and then it goes.
And if it won't come through, so it's a little more rigid or fibrotic or
So it doesn't
or
squish down.
calcific,
Yeah.
right, it won't deform and come through. That's when you can you keep the flow up, and you take the entire can. You have a dry sheath out.
Yeah.
And then you can turn it off.
Yeah.
And then you can, get it to where it's operational
Yeah.
again. And that's where you can use this filter for a little bit of
Okay, so let me ask you, it looks like you have a shunt line here. What's your shunt line for? Because it's clamped off.
So I'm going to show you. So what I was concerned about with this patient is that we would lose, they would have a big PE and crap out on us. So knowing that this could become occluded,
Yeah.
I have this line so that I can suck. I could clamp here. Let me see if I have a diagram. So here we are now.
I see.
It's not occluded. I'm draining the patient, so we're still able to do the therapy.
Yeah.
If we had flow, right?
Yeah.
Until you catch something. But we swapped it over, and now I'm oxygenating the blood, which we could switch over to the femoral artery if we wanted to, or just oxygenate the patient's venous blood like VV ECMO.
Mm-hmm.
And that's just by moving these clamps. And then if your filter was occluded, you would pull this back so you don't capture any more material
Right.
and trash your pump. But in this particular case, you can see that it's coming down. It's bypassing the filter to the pump, into the oxygenator, and then into the femoral artery. You basically would have VA ECMO support at
Right.
this point in time. So it buys you time to figure out, what do I need to do next in order to continue with this procedure? But that big 22 French actually gives you pretty decent drainage.
Yeah.
I've flowed 5 liters with it before.
And let's see, 22 front, 20. That's what I guess. Is it only come in one size?
I believe, I'm not positive. I believe
this
so,
this
though.
one was 22 French, but I feel like this one was something different. The case
Maybe
study.
they have a little smaller one. I don't know, but they have one that has an angle on it.
Oh no, this just said they used a 25 French sheath to insert the AngioVac.
Right, so you use a gore dry
Right.
sheath
Yeah.
is what you use,
Yeah.
so
Okay.
that you can
So
put
I was
it in.
wondering about the size on that. So I mean, that's really smart that you put the oxygenator in.
Right.
Similar to when we did that left heart bypass, because we don't
Yes.
have a left heart bypass circuit per se, because
Right.
we don't do them.
Right.
So we modified an ECMO circuit, clamped out our oxygenator because we don't really need all that extra volume.
Correct.
You know, and
But if we needed it,
we had it.
we
We
had it.
just had to open it.
that's right.
Yeah, it was an ingenious design. I don't know why we don't sell those.
I don't think it was that ingenious. I think it's been done many, many times. I learned it from someone else, likely, and then that was the end of that. So that's what we did, and that was such. I mean, that case, and this is the actual case. This is what we got out. So what you had seen was, it looked like a big ball.
Yeah, but it was really stringy.
Yes, and it was just all coiled up on itself.
Well, and it had to be because the way it was going in and out, there's no way that the big ball would do that. It had.
But what was it holding? We never figured out what it was holding on to. But actually, this was a really fun case because as we were doing it, this is really true. So here's our circuit. And that's actually, isn't that Min? That's Min. That's me. Yeah, that's Min. That's who that is. That's me. And so we had it set up like this, okay? And so Dr. Batoyer gets it in, and he's going down, and we're on VV, right?
Yeah.
And by the way, you can claim these as bypass cases.
They are.
This is bypass for your ABCP. So
So I guess it's like it would be just like a left heart bypass. It's just
absolutely
different.
It's just right. It's just VV bypass.
Yeah.
It's right. That's all it is. But it's still bypass. And but anyway, I had all this elaborate stuff set up, which we didn't use, but never had to use it because we got. But anyway, we turn it on. He says, "Okay, I'm in. Turn it on." So I turn it on to get flow. The flow went up and down. It just went whoop, and I was like, "What?" And I was like looking at it. I mean, he was still in the IJ. He was not even in the atrium. And the next thing I know, I saw the flow come back up again, and I was like,
Had he already
I
caught a
don't
clot?
know. I said, I don't know what just happened. And what he said was, because it was kind of an elaborate system, and I was concerned about what we were doing. What he said was, "Did you have it wrong?"
Right.
But I heard, "Did you have it on?"
Yes.
And I said, "Of course." And he takes all of his stuff and he throws it down and goes, "Oh!" Because now everybody's like waiting for impending doom.
Yeah.
And I said, "Did you just say, was it on, or what did you say?" "No, I asked you if you had it wrong." And I said, "What do you think I am, some kind of a rookie back here? Of course it's never wrong. It was on." and everybody, and they were like trying to clear the trap with light up to it, and I was trying to flush it out, which you can do. You'd see that, and then we saw this big. Dude, the room erupted. It was like, it's so cool when it happens.
Everyone's so happy.
Yeah, and you look at some of those images. I don't know if those. I mean, you look at some of this stuff.
Incredible.
I mean, that's just amazing. That, you know, because I mean, that's lethal.
Yes.
That is lethal.
Yeah.
You know, this thing is lethal.
That's crazy. Yeah, it does look like a ball there, but
It does.
you wonder how it's springing down like that. You know, if it doesn't have a tail or something.
And what was it attached to? We never really figured that out. They didn't have a line in there. But we've done this. I've done this with Matoyer for cases like that. I've done this with where they wanted to pull a central line out, and it had a big infected clot on it, and we've cleaned that off, and then be able to pull it out. I mean, it's really a neat tool to have in your tool chest.
Yeah.
I think it's absolutely worthwhile.
The first time I saw it was at one of
the New Orleans conference.
Yeah, it was the New Orleans conference. I remember walking around the vendor area with all the the displays and things, and I walked by, and they have it sort of in a flat display showing it supposed to be like, in fluid in a body.
The vasculature.
Yeah, and it was so neat. I was like, what is this voodoo?
Exactly. I know. I miss doing that. I really miss that.
I know. Well, let's do one.
I know. We keep saying it. I know. David, are you ready to go? Are you ready to go remote? What did I say all the time? What do I call it?
On location.
Are you ready to go on location? No. No. Okay. All right. Well,
David decides everything around here, so
correct.
That's
it's up to David what we do, but no, it's a great tool, very useful. I really think that it is, in some places maybe used to its maximal capacity. I'll say it that way, and I think in other circumstances, it's, I think, a grossly underused technology.
Yeah, it's on the shelf, and they're not really utilizing it, huh?
Yes, to its full capability. So I don't even understand why that is. But we have had a rash of cases, and I've enjoyed every case that I've ever done with it. So I think it really has. It's pretty useful. I really like it.
Yeah.
Oh, I remember that case I was talking about. Now I had gotten it wrong. It was an IVC filter, and
Min couldn't have been in that case because Min stayed with me.
This was the case I told you about. It was the disaster.
Oh.
And they had put the femoral venous return, and they put the right IJ in and had it in the atrium, the AngioVac catheter in the atrium, and they were in there trying to use snares to get the IVC filter out.
That's the one that y'all had to urgently leave for? No.
No, this is a different one. And where misuse of the device made a difference.
That was it.
And that filter was completely occluded. It was really, 90% occluded.
Yeah.
It had to come out. And we kept saying to this guy that's not here anymore, that we don't have it turned on because you want to turn it on to protect you. So you want to actually be in the IVC superior to the filter, so that if
you can catch it,
anything comes out, breaks off, you catch it.
Yeah.
And so, but he refused to turn it on. Put it in place, but refused to turn it on. And
this is the doctor.
Yes. And we just kept saying something. Anyway, the patient acted funny before we left the operating room, but then they got the filter out. But when you looked at the filter,
using the AngioVac system.
No, they just put it there and never turned it on.
Oh, it was just for safety.
And that's, yes, but it's
Backup.
not safe if it's not turned on.
No, I get it, but that was his idea. This would be here just like in worst case
scenario. No, we have no idea what his idea was. Okay? No, the fact of the matter is we don't know what the hell he was doing, to be honest with you. This is what's scary about it. My point is that without it being turned on, it was just a catheter stuck in the blood vessel.
Right.
So when they got the IVC filter out,
Are you going to tell me there's a part
and
that
you
was clean?
looked at it, yes, that was the one I was telling you. There was a piece missing,
Oh no!
and like that looks weird. It looks like it's just missing.
Because it would,
And-
if it was all clotted off, it would be clotted everywhere.
Yes.
Yeah.
And there was this big chunk missing. And anyway, that's the patient I said they got to the ICU, and they turned the patient.
Oh, and it moved it.
And it probably got into the ventricle and it just was stuck maybe on a cord or trabeculi or whatever.
But moving it
and
mobilized it.
Went up, and they ended up doing an emergency pulmonary embolectomy. Of course, the patient was already deceased, and they took the piece out. And when you compared that chunk
It was
to the filter,
piece.
it was like a puzzle piece. It was a perfect match.
Wow.
So
That's incredible.
having it in place, my point is it's useless if it's not on. Conversely, if you have something that will automatically turn the pump off after you have engaged something, you're running tremendously high risk. So the authors of that article, if they happen to see this, I would stop doing that, because if you have a competent perfusionist who's paying attention, first of all, and you're not going to get an air embolus, because if air goes in there for whatever reason, I mean, it's going to deprime the pump anyway. But I mean, so it's not going to just pump the patient full of air. You're not gonna, that's not going to happen.
Well, they talk about micro air too.
I mean, really,
well, I don't have any real experience with using those automatic occluders. I know they're offered places, but
I would never use it.
I worry about anything that's going to occlude my line.
Yes.
In a time when I don't want my line occluded.
Right.
What's the reset time on that? Getting it released and doing all of that.
And if you can't get it released.
Yeah. What if it stays stuck?
Right. Or there's it malfunctions and you can't get it open. That's very concerning to me too.
So I've never used one.
Right. There are
I have clamps. They do that.
Yes, there are much better safety mechanisms that are just as effective as that and much safer. But you know, there are a lot of people that do that, and you know, there's a lot of reasons for things.
But I don't have any experience with it.
No, but in this particular case, with that diagram that you had, I would recommend that they cease using that bubble detector, because I mean, you would have to have a lot of air to deprime that reservoir to begin with. You'd have to be pulling the thing completely out, in which case you don't have to worry about it at that point. You got a bigger problem on your hands, and that is you got to put the thing back in. But anyway, great journal club.
Yeah,
I appreciate
pretty
it. Okay.
Interesting.
Now, we did get some good questions. We got from Greece. We got from Azerbaijan. We got Robert Parchman from Shreveport. I haven't talked to that guy in so long. Man, it was interesting to see that. And who is the other person we got? We got somebody from
that Magic said in Australia.
from Australia.
Do
yeah,
not say their name.
So yeah, I'm not going to try. I'm not going to try. But nobody called. But I think we're still going to do. I think we're still going to do a spinorama.
Well, have you made an announcement that unfortunately John is not able to join us
Oh yes,
this morning?
I forgot, John. Yes, no, thank you. I did not make the announcement. So the
anybody who's waiting for John's presentation.
Yes,
sorry.
we went long. We were waiting till the last minute. Thanks for reminding me, because we weren't 100% sure, but he had an emergency situation, and so we went long with this to
allow time.
To compensate for that. But it ended up he's not able to make it. So we wish him well, whatever the issue is. I don't necessarily know if it's him or it's a case. I'm not sure. He just said that he had an emergency situation. So let's all make sure that we keep him in our thoughts with whatever the situation is for him or the patient.
And I'm sure that knowledge nuggets will be moved to
Yes,
next time.
we'll do the knowledge nuggets another time. That is true.
Who knows?
Absolutely
Maybe we
true.
can get a double dose of John one day.
We can get. I don't know if we can take that, but I think one dose is good.
A gem of the week, 2 of them.
Yeah, the only gem of the week should be our job, okay, or our conference, or our programs. That's it. Those are the only gems.
I like his gems. We did a quote one time by Einstein, which I really liked, and I like his gems of the week.
I can give you a great Einstein quote. I'll give you a gem of the week. You know what? Gem of the week.
Let's see.
So
Let's
Einstein, it's a quote.
see. Okay.
So Einstein said that the difference between genius and stupidity is that genius has its limits.
Yes.
That's true. That is what he said. He
Yes.
said that. Okay, so we're going to do, are
Yeah.
we going to spin?
Yeah.
Who are we going to spin for? Let's spin for somebody.
Yeah.
So-
well, how are we going to choose who?
I don't know.
Well, why don't you say
Okay.
first person to respond back now?
First person to respond back now on the FaceTime or the
Facebook.
YouTube.
Facebook.
Yeah, say Facebook. No, Meta
It's
or
not called that.
Meta or Twitter or here on the YouTube.
Okay. If anyone's stuck around after
Yeah,
Matt's
we
great
got people.
presentation.
Anybody here? If anybody says anything, Magic, you're watching the other. Hey, Klaus, spin for Greece. Okay,
Spin
good
for
job.
Greece.
Good
Yes,
job.
Yes, yes.
All right,
okay.
let's go. There you go. Where's the sound?
Yeah, wait, there's no sound. It's not fun without sound.
I mean,
wait.
really?
Hold on. Just there, wait, I got it.
No, hold on,
All
hold on, hold on. No, they get
No, that doesn't count.
Yeah. Oh, Klaus, you get an aortic dissection.
No, I want sound, Klaus.
You're gonna
you get another
got an
spin.
aortic, and it's the right time of the day for you to get an aortic dissection. Always in the
No,
middle
this
of the
is
night.
going to be something good. Good for Klaus. Good for Greece. Oh, no.
Extra call on top of it. So, Klaus, you get extra call and an aortic dissection. Okay, one more spin.
Come on.
Come on.
Let's go for
This
Greece.
thing is legit. Okay, this thing is legit. You can't fix it.
No,
It's legit. No, the thing
I'm
actually
getting him
does
something
work.
good. We're spinning until he gets something good. All right.
All right. So
All
you're
right.
gonna get cups. We're gonna send you cups. We're gonna send you. Here, let me grab it. Hold on. We're gonna get you. We'll send you a care package. We're gonna send you a care package because we want an invitation to come visit you.
Yes, I'd love that.
So we're gonna get you. Let me grab
So,
this.
Joe's off screen from our
Let
prize
me grab you
closet.
this.
And
where's the scrub caps?
they're in the box. I
They're
think.
right here. Okay.
Yeah. So go
I'll
to my
come over
camera.
here.
Okay.
Yeah, so I'll just do it right here. So we're going to send you a couple of T-shirts. We have different colors. They're really cool. It says Perfusion. We give your heart a rest. Cardiac surgery. We have that. We have scrub caps.
And they
Take my
say the
glasses
same
off.
thing.
They say the same thing. Yeah, we have some pretty cool scrub caps. There you go. Yep. Tie that up. Make it look pretty. Make it look good. You look official when you do this. And then we also have these ball caps, and these were all donated. I can never remember the guy's name.
know. We
John
have to
is
write
always
that
saying
down.
it. So
Mhm.
there are these ball caps. These are pretty stylish things, and it's got a catchy phrase on it. People will be like, "Oh, what's that all about?"
They will.
So,
They'll ask us if we perfuse livers.
Exactly. So we're going to be sending you a little care package with the cup, some scrub hats, T-shirts. You'll get everything from us, Klaus. Thank you. Thank you so much.
Awesome.
You look awesome, Joe. I know. You know how hard it is to be me?
Yeah, we need contact.
Oh, yeah. So,
Email
Klaus,
us.
make sure you send us, go to contact@perfusioneducation.com and send us an email so we have your address so we know where to send it to.
Yes, absolutely.
Okay, very
All right.
good. Tammy, I'm going to let you close us out today.
All right. What's our next date of our next show? David? It's on a Thursday.
Mm-hmm.
It's the Joe solo show lately.
Yeah, I think we're going to do
Okay, so on November 18th at, I believe it's,
Mhm.
2:45 in the afternoon?
Yep.
What's our topic?
ECMO. Who, how, and for how long?
Oh, yeah, that'll be a good one.
It's going to be a good one because, right now we are exploring
Yes, finally.
very seriously our both selection criteria
Mhm.
and our manner in which we
Evaluate
consult-
progress.
Yes, yeah, very good. That's a great way to say it, exactly,
yeah.
because that's something that has been a real issue with patients on ECMO indefinitely. and
Yes.
families that are put in the position of having to, we're really changing what we're doing
Yeah.
dramatically.
Which I know a lot of places have done this, but it's been
Yes.
slow to come to Houston.
It has been, or in our practice. I
Yes.
don't know that it's been slow to come to Houston. I
Slow
think
to
it's
come
been
to
slow to
our
come to our
hospitals.
practice.
Mhm,
Yes.
mhm.
Okay.
Well,
Well,
thank you everyone for joining us. We hope you enjoy the rest of your evening or day, as it may be. And
night for Greece.
yeah. Well, have a good night, and we look forward to you joining us next time. Thanks a lot.